teaching priorities are most valuable.
Barely. If this part, if I can just make one quick clarification, if that's okay. Sorry about the sound. We really thank you for your time. Let's wait for the second. People.
quite a number Used to do and you guys £3, you bring back 2 kilos.
Hello, hello, hello.
It's always lovely to hear.
Turn on volume now. You just check.
I see you because they get the hello, yeah. Avoid that. Tomorrow, that's what I always say, yeah. Yes.
Is that worse? We get tested.
You're talking.
Yeah, it just seems like nice.
Oh, yes. I'm still traumatized over. I always remember this.
Yeah.
People are here. Everyone does it bleed for. They choose dogs. Was sitting in the clinic, but that was
Well, I can press me a member on this screen over here. Look, I fell on the tape. Feel like I've got a job. How are you?
Good to see you. And long time no. No, it's been a while. How are you getting on?
All good.
Yeah.
Yes.
You know, same shit as always. Yeah, yeah. How's the new seat here?
She's great. Like it's a big change.
I thought it's a bit close. Yeah.
I think he's coming. I think he's coming later.
Also big shoes for her to step into because Paula was like so
Well known and like.
Yeah, lovely. I met her a couple of times.
Yeah, I know.
around.
So nice.
Yeah.
So personable. Like he instantly kind of someone that he inspired, which is what you want. Yeah, we've been trying to get scripts like we're that now.
Good. Yourself now kept going. Yeah. Funny actually, because
Hello.
August died. Yeah. And then September came and everyone was like, we need space, we need to book in, we need to do this. Everyone was reaching out, so it was a bit. First, yeah.
You hear me?
Yes.
And even if you want to do something, you had to be made around. And suddenly September arrived.
Yeah.
You guys come from conference in November.
I have to sort that out. Yeah.
This is only the teacher line.
Okay. I'll put that top of my list. Yeah. And let me know if there's anything I can do or anything, you know. Like I've a bit of
One of the things that one of the sessions that is going to be around homelessness.
yes. Yeah.
From Focus Ireland, it's going to be kind of leading that, but I didn't want to know you guys.
That'd be brilliant. Yeah. We can do. Yeah. That would be brilliant. Yeah.
As much as possible for like the actual information we need.
Yeah. The cost down. Yeah. No, next week I have it earmarked to like who we have going. Bring the new wife. I don't know if you met her yet. She'll be here later on. You should say hello. Yeah.
I have
Lovely.
What you might even my boy being back. No,
You were talking about how great the coffee was. Just say a bit about it.
like the voice of God started speaking. It was like, oh, actually, maybe it's not. And are we about to get raptured?
Oh my god. It just kept coming across my feed. So I was like, I'm going to be raptured, which is great, you know?
I get raptured and don't all the worst people in the world.
Yes, exactly.
You're right. We'll jump from like
Distancy. Yeah.
Oh,
Yeah. Well,
How are you getting on? GMHS.
do anything for you, you know, we're happy to help. It's possible, yeah.
I
was going to ring
Everyone can hear me being like,
Didn't notice that.
the bus. Show up and look pretty, that's what I mean.
so it's just like, yeah, you know, someone would tell me, how are you? Waiting for those buttons.
the reception. Yeah.
I have a feeling those samples are after
Professional.
Maybe 5, 6, like
No,
this.
I think we just get to the same myself. I'm happy enough with that. I've got good job. So I think yeah. So when it switches from a person to speak to a person, to be honest, that's impressive to make a character change.
Why not?
Person. Yeah, but. Debrief next week.
Okay, fine. Not this morning.
Only there's 8 people on there, but is it recorded? Do that as well?
Already protected, so fine. That's what I keep
Professional actors into the job.
Oh, time no see. Oh, I was like, are you going to go for a handshake?
No, exactly. They were the floor body, right?
Yeah.
Suppose you get a full room.
The one that's there on the right hand side was last week. Lesser in the reception area.
Yeah. Standing room body, but that doesn't mean you want the appearance of standing. Yeah, you want to feel like they're out of bed. Couldn't be second row, but it's here. Well, I think right now it actually feels complete. More if you're actually going to feel too many. And then I think even like when the space is there at lunchtime.
Yeah.
I'm sure they're saying
That's one thing about here, and that's they did there where people shoot their own would be great. We link them in the app. It's very good. I didn't know that. Well, I was part of the
You only have a level do that, so it will
there are contribute staff. Like an older brand.
They brought
around this house. So you can scan.
But along with page and opportunity, within that, he was trying to kind of incorporate LGBT specific older programming within that with some success. I think.
I remember for the I remember I was dealing with an age yeah. Sometimes I think that
Even I scan.
yeah. That thing he was doing that I can pick up for him.
Oh, and do it. Okay, you do. Do me a favor. You do what you have to do. I need to check in the. Yeah, but we have a chance. You know, one year.
Like
We're gonna kick off again, so please take your seats, please.
someone on the street.
Okay, yeah, it was perfect. Straight. See you website.
Tiny bit of that.
You know, these pages just say.
But it's a picture, look, it's just.
I'm not walking around and I'm like, with pictures of the world that I'm stalking.
So we've reached.
What? We're.
It's actually.
I'm receiving so other people will be away with it.
Hi everyone, we'll just kick on with our next talk. We have Colleen Finley, who's from Monaghan, like myself, and is a prep nurse in the matter. So, Colleen.
Hi, I'm Colleen. If you already know, I'm the practitioner in my hospital. I'm going to with A recent patient survey. Service was established in 2019 in one CNS, which was David back in the day, and myself as a health advisor. We appoint two of a consultant and one admin officer starting off, and then of course COVID happened, and we were all really behind a couple of months, so prep didn't get up and running for another while. So that's where the virtual appointment came into play. People was set up, and we were able to do what David was able to do. Able to do a kind of a Zoom call assessment, and then it was deemed safe for people to come in for tests, and they're able, we book them in, or we book them in. I'm giving credit where it's due. So then that was until he left us in 2022. So then I was the new prep student from 2023, and then we had a new part-time consultant. So we hit the ground running. We closed and cleared the waiting list. From 2023, we did about 500 appointments offered, but then we had no waiting list, so there was no proof of demand for the service, so there was no real funding then, so we had to reopen the waiting list in 2024. So we have, these are our numbers just from 2024 of what we were seeing. About 2,558 total attendances, and we had 55 new prep users in 2024, and 77.6 assessments were done by myself or by Elaine or Paul if I was off. So with the national standards, we looked into, having maybe some patient feedback. There is a feedback form on the Matter website, what we wanted to kind of like target the service just to see how we were doing and what we can improve on. So in February 2025, we carried out a patient service survey. So we gave 4 weeks notice to potential participants via posters, word of mouth, and automatic reply via email. We emailed each 846 service users on Valentine's Day and asked them to reply. That wasn't actually planned. To reply for 2 weeks, and they had the option to opt out. So we had 245 total respondents. Good, apparently. So age group kind of ranges. Majority are age 35 to 44, and 80% were on a waiting list before they were offered an appointment for PrEP. 42% were waiting 6 to 12 months on the waiting list, and then there was 26 waiting over a year. 50% tried to access PrEP from another service while waiting for appointment with ourselves. So these are all the services that were tried, or were at the top 3. Obviously, Guy, Gayman's Health Service, and Vincent's were the most popular. There was some in the Midlands, and then for private, there was kind of where the Trinity Clinic seemed to be the most popular as well. 55% of people said that they were unable to access PrEP either privately or through another source, with 10% saying that they got their PrEP from a friend, 17% from private, and 9% from another public service. So 50% have been with us for about 2 years or more. We all know each other very well. So we communicate quite well. We have a dedicated email that's monitored by myself and one of the admin officers. And then we don't have a dedicated phone service, but we usually phone people back within a 24-hour window period if they have any concerns or questions. So some improvements. Which was just kind of like a word bubble thing, so there wasn't a list of what email appointments, how we can improve on our communication. So we have 2 clinics. One is based in 70 Eccles Street most of the week, and then we have 1 evening clinic in Clinic 6 in the Mater Hospital. So it's just the volume of people attending, we kind of are spread out a little bit, which is thankfully our service users are quite nice, like, oh, we showed up at the wrong place. They're just happy to be seen, I think. But it'd be nice if we had 1 dedicated space, but that's all. And the Mater Hospital is easy to find as well in Clinic 6. So we're friendly and approachable. We gave people the option to ask questions during their assessments and got answers that they understood. They have confidence as a provider, and that they were given enough time and privacy during their appointment. And they were treated with dignity and respect too, which is good. So with the virtual appointments, most people would have availed this unless they were coming in kind of more complex every 3 months. So 90% said that they have used the virtual appointments, and that 88% said they were convenient. So we use them with SH24 if they didn't have any concerns. They were advised to use SH24, or if they wanted to come in to get tested, that's no problem as well. So 54% would prefer virtual appointments over in-person appointments, and 54% would prefer just all prep service be provided through telemedicine. So they'd like to see us, like 49% would like to see us every 3 months, and 38% said every 6 months, and 8% said every 12 months. 83% said they were quite satisfied, very satisfied with the service. And was there any additional services that we could provide to make your experience better? So highlighted was more education, more condoms, more lube, more self-testing options, and then direct access to results. So unfortunately, we do the 2 weeks if you don't hear from us, everything's fine. So we're all in charge of our like clinical inboxes, and we do have a nurse that's kind of like a safety net, kind of making sure all results are being actioned on. It's just with our system is very old, and they're not putting any more money into to be able to text people results. So, but patients are always told that they can email in if they actually specifically want the results. So other suggestions would be more education, car parking, doxypap, and just, I suppose, more kind of like counselling and support to do with substance abuse problems. And just see, oh yeah, additional times for people that work Monday to Friday, more latex alternatives, and believe that appointments every 6 months would be better than having a self-test in between would make it easier for those attending. So we did ask, should the HSE provide more funding? Thank you. The staff was deemed the best aspect of the clinic. The worst was kind of obviously word bubbles, but waiting time seems to be the most problematic. So waiting for appointments, and then if they had any comment on Ireland's National PrEP Service. So like that kind of I know word bubbles, but I see rural, and kind of I presume like people are happy with it, but probably needs to meet kind of a more national service. So what now? We just full transparency. We have 886 currently in our service, 325 on the waiting list since May. We've 105 new PrEP appointments since January. We're kind of infiltrating 3 appointments a week for new service users. And 6 monthly appointments are encouraged with the use of SH24, but we're facilitating 3 monthly if people want to come in. Introduction of doxypap for PrEP users is requested. And we have medical social worker and a new clinical psychologist as on board as well for referrals if needed. So with we're kind of brought forward to the matter about, you know, access and results. Is there a way of that we can have like a texting or like a portal, which SH24 is great. You can see all your history. It'd be great to have something like that. But again, our system is so old, they don't want to put money into it. So we're looking at transformation within the matter to see if there's anything else we can do. I'd like to bring in injectable PrEP into the clinic. Really eager to get that up and running. And it would be nice to have a dedicated community service for sexual health in North Dublin. And also I kind of put in as well that maybe for nurse-led PrEP services, I know I'm a prescriber myself, and I think it just makes life a lot easier kind of like having that on board, and you get to know people. You're not relying on the consultants, no offense, but I think, but no, the nurses I think are well able for themselves. So our service runs Monday to Friday. I'm off on Thursday, but this is our working week. We have clinic on a Wednesday, or sorry, on a Monday afternoon now, and all day Tuesday. Other clinics on Wednesday to Friday is myself seeing people that are using PrEP that have symptoms or emergency, and then reschedule appointments as well. We don't have, just to highlight, we've no staff nurse support when we're in 70 Apple Street as well, so it's literally us running service. We have our health advisor Elaine, who's managing PrEP, service user infection and partner notification, and she also is the point of contact for anyone that's using SH24 and that need treatment or follow-up testing. We have our vaccine CNS Lose, and then we have our AMP Paul for our sexual health as well. And these are our numbers at the moment. So we've had 105 new PrEP appointments, 60% of them assessments have been carried out by myself or again by Elaine and Paul if I'm off. And that's it. Question?
Hi, you mentioned future plans for injectable PrEP. I was wondering, could you talk more about that? I'm assuming it's cabotegravir kind of thing.
So it's something I would like to bring into the service. A lot of people are asking for it already, and my excuse is, oh, we're Ireland, we're a little bit behind on everything. But I would see it working very well into the, like, we'll be doing the virtual assessments and bringing it just for the screening and STI care, and then doing the injectables as well, where we have our HIV CNS Amy that's doing injectables for people living with HIV in the matter already. The uptake is kind of slow to start, but I think it's because it's the working in of you have to commit to every 2 months and then, you know, that kind of way. So it's something I think, you know, would be great going forward for PrEP, and there's a lot of interest in it as well. So yeah. Anything else?
Just with my GMHS hat on and having worked in the UK, it's going to be a little bit of time before LACAB becomes available. Unfortunately for PrEP, we're working hard to make it available. There are a number of patients I've lined up already to just. I'm working with the drug company to even get compassionate use access to LACAB, which we do have in the UK, which is a unique, one of the very few benefits of them not being within the EU. So there are reimbursement issues with it. It's going to be, there's really probably nothing in the pipeline for the next 12 months, but we're keeping it under review, and we're working hard to try and get at least named patient access to it directly through the drug company, even before it's approved or reimbursed by the HSE. Yeah. Thank you.
Thank you.
Colin, next we have John Gilmore, who's going to be talking about a survey that was conducted on PrEP in Ireland.
I did send in updated slides on Thursday. Are these the updated ones? No, they're not. I see Paddy's face. Robbie, your name's not on the slides. I will definitely. Oh, are they? Oh, then Robbie, sorry, I shouldn't have said anything. I don't know why I didn't. Hi, everybody. I'm John. Any pronouns. I'm assistant professor in the School of Nursing, Midwifery and Health Systems in UCD. And yeah, so I want to talk to you a little bit around a national survey we conducted last year around doxyPEP in Ireland and awareness, knowledge and use amongst, I just did this to annoy David, at-risk communities, but most of them are gay and bi men, and that's a lovely visual there from Pradeep, who provides us with some. Oh, it's doing the no. Great, Tom. Yeah, yeah, so
I think the slides up, the PowerPoint slides up as well.
That's great. That's what. Yeah, so this is, yeah, no, they're not the new ones, they're the old ones, because Robbie's name is on it. So this is, oh, I'm going to just destroy the place. Come back. Can you come back? It's moving now on its own. The back, another one. Back, another one. Back, way back. Sorry, everyone. Back, another one. I just want to show my team, including Dr. Robbie Lawler from University of Galway. So this is who supported the research. We were not funded to do this, but we had a nice team of psychologists, epidemiologists, nurses, and a consultant. Imagine even I worked with the doctor. Imagine that. So next slide. So this is basically a background for what we do. So doxycycline. So we know that, and we have heard that bacterial STIs remain a challenge, specifically for communities of gay and bi and other men who have sex with men. So we have had some recent declines, but we still remain with significant rise when we compare it to pre-COVID. Like most kind of STI work globally, most of our focus is on a test and treat strategy, but you know, we still have these rising rates, so it's not sufficient to meet the need of reduction of STIs. And along came DoxyPEP. So DoxyPEP is taking 200 milligrams of doxycycline. I had that in my updated slides as well, because I forgot to tell the definition or description. So DoxyPEP is 200 milligrams of doxycycline taken within 72 hours of condomless sex, and shows significant reductions in some of these studies, which are focused on DoxyPEP, but also real world analysis in places like San Francisco and across the US and in France and other areas. So uptake in Ireland remains underexplored or unexplored. We have no formal guidance around the use of DoxyPEP. As you saw earlier, there is some interim guidance the HSE produced, and we produced some community-focused guidelines. I was also involved in writing the British Association for HIV and Sexual Health guidelines on DoxyPEP. And I suppose we're in a space where we wanted to understand, well, anecdotally, we know people are using doxycycline in this way. How are they doing it? What's their understanding? And yeah, what are the trends? So next slide. So basically that's it. Awareness, knowledge, and predictors of doxycycline. We ended up with quite a bit more data. We collected quite a bit of data and some really interesting stuff on the survey, but I'm not going to present all of it. Next slide, can't remember what it was. Yeah, there we go. That is what I want to do. So we did an anonymous online survey for about a month, focused on gay and bi and other men's sex with men. So it was based on a survey that was developed by colleagues at Fenway in Boston, Massachusetts. So they had about 900 gay and bi men in their survey. I didn't do any sophisticated sampling or analysis of power. I just said, they got 900. If I got over 100, I'd be happy. Because you can tell I'm not a quantitative researcher. I have some really great friends who are. So we looked at people over 18 and recruited by a LGBTQ plus network. So thank you to Man to Man, thank you to the Empower program, thank you to all of the different community organizations who supported this. And then we did some descriptive analysis and also looking at some determine the predictors through logistical regression. Next slide. What's next? Oh yeah. So we had 151 participants, about 178 people clicked on the survey, but 151 complete responses. So median age of 36.3. So we had from I think 21 to 78. Like similar studies we've done on gay and bi men in Ireland, mostly white, mostly cisgendered, mostly gay, and a scattering of others. About 8.6% of our sample were people living with HIV. 68.2% currently on HIV PrEP. Quite a large, I am going to use the term, and people know I hate this term, a large STI burden within the community. So most, 80% of our sample had an STI ever, and about 40% in the last 12 months. And less than that then had multiple STIs in the last 12 months, and quite a highly educated and moderately well paid population as well. Next slide. So we looked a little bit around sexual behaviours and attitudes to STI. So 70% had 2 or more anal sexual partners in the last 3 months. 63% had group sex, and that was a 12-month. Condom use was low in the sample. I don't think any would be shocked and horrified to know that. We know that. Keep talking about it. We know that. With 40% never using condoms, and 87.4% prioritize STI prevention. So we asked people about their attitudes around STIs as well. So for people, sexual health was very important for people. They wanted to avoid STIs, but they weren't using condoms. So go figure. People don't want to use condoms, maybe they won't. And that's where DoxyPEP comes in. So our sample, a lot of our sample were already aware of DoxyPEP. So again, without any campaign, well, I mean, we had the community guidelines, so maybe that was impactful, but I think gaze to all. I think that's something we know from the launch of SH24, when we took all the packs straight away. We know from the big demand of the Mpox vaccine, like our community is very engaged in terms of health responsiveness. And almost 70% were extremely interested in use. And we had almost 30% of people who are currently using DoxyPEP. And we do know that DoxyPEP is not available in all of our public STI clinics. We know that people who potentially and possibly and likely and definitely, as somebody can test personally, meet kind of criteria for DoxyPEP and are being refused it in public STI clinics. Fiona's not here yet, but I'll say it to her again later. Fiona doesn't refuse them, that's fine. So people were using the recommended dose, people were using DoxyPEP adequately. We asked about kind of broad antibiotic use, and people were mostly using doxycycline. There was a scattering of people using other antibiotics which aren't evidence-based, but most of them were using DoxyPEP, and most of them were, almost all of them, using it properly. About half of the sample were accessing informally, so that was through friends, through the internet, through leftover antibiotics, through going on holidays to somewhere where you can buy antibiotics over the counter. So we're not accessing in our formal sexual health services. So we do really have to question, what's happening here, and people are being asked. We most reported no change in condom use. So if they weren't using condoms, they weren't going to start using condoms, DoxyPEP, because that would be a bit ridiculous. But also, if they were already using condoms, DoxyPEP wasn't changing. So there's that. And then we asked about concerns around the actual treatment or the prophylaxis. And I think what's really important, and these are some of the kind of conversations I have with clinicians as well, people are conscious and aware around antimicrobial resistance. It's not that gay men are ignoring that there's potential. It's that sex is important and sexual health is important. So it's not that people are ignoring the fact that there is potential concerns around antibiotic resistance, but there are issues around understanding what AMR is. And then other people, inconvenience, cost, long-term side effects. Very few people were concerned about their adherence. They were confident they would be able to take it properly, or privacy wasn't a concern either. Next, is this the predictors? Next slide. Yeah, so we did logistical regressions across different kind of predictors that we would expect, but also that were there, and it kind of surprised us in a way. So some of the things that weren't necessarily surprising was there was no difference in people living with HIV versus people not living with HIV. PrEP was interesting because basically everybody who was taking DoxyPEP was also on HIV PrEP, and that's really positive because that means that people who aren't living with HIV aren't putting themselves at risk of contracting HIV by avoiding other STIs. Chris annoyed me at one point, he's like, maybe you should check for collinearity. I don't know what that is. A nice man on YouTube taught me how to do it. So we were looking at, the predictors where there was significance were previous use of HIV PEP, so kind of that experience of having maybe a fright, a risk, and group sex. But then the surprise was that while group sex was significant, Sex on premises venues and saunas wasn't significant. Chemsex wasn't significant for us. So that's where Chris asked about culinarity. But we did all these fancy things, BIFs and things like this that people may understand better than me. And we didn't find that that was the case. But really what we found in terms of predictors and overall of the people who should be on DoxyPEP aren't, like, nobody's taking DoxyPEP that wouldn't necessarily benefit from DoxyPEP, which is really important to say. Next slide. This is where I'm giving out about things. Yeah, so we're already using it. So I think, you know, clinicians need to be aware of that and need to be conscious of their role in terms of supporting people to make their own decisions about their sexual health rather than restricting people from accessing things that would benefit them. We saw this with HIV PrEP as well. An overly restrictive system is not conducive to anything. There's high awareness and real interest in it, but kind of informal use and access. You know, when we buy our drugs off the internet, we don't really know where they're coming from. So I think we need to be conscious of that. Need for structured clinician-led, but also community-engaged guidelines. So having more formal guidelines may be useful because we will use them in the community. We will say, well, there are guidelines when we're having conversations with clinicians who may be refusing to provide this for us. And there may be I feel like I'm clinician bashing. I'm a clinician, I'm a nurse. But, you know, I think there may be very clear rationalization of why somebody shouldn't be taking DoxyPEP or what might need to be taking DoxyPEP. But I think kind of overarching kind of perspective that we don't provide that maybe are damaging to relationships between us as communities and clinicians providing this care. And yeah, so guidelines should prioritize stewardship, and that's not just stewardship from the prescriber, but also from the person using as well, and having those kind of good discussions, education, community engagement, and inclusive access. I think that's me, is it? Yeah, done. Am I? Thank you. Yeah, thanks everybody. Quite another review with more of the data, so we'll send that out when we have it done. Any questions?
Thanks so much for that. Such an important topic, and for raising the perspective of community in that. So I want to be really clear at GMHS, we are not holding back on DoxyPEP. We're proactively discussing it with patients. I just ran the numbers there just to give people an idea, but 125 people we've started on, or scripts of DoxyPEP we have administered since the start of 2025. So even before the batch guidance came into was fully approved, and Fiona will talk about the Irish guidance as well. Of course, you'll know that yourself and herself have been active on writing those, so that will help to hopefully give clinicians more confidence to prescribe it. But from a personal perspective, I know I hopefully can speak for Fiona as well. We strongly believe it's important that we raise this proactively with patients. There's an evidence-based intervention that can significantly reduce the risk of syphilis by 70 to up to 80%, depending on what studies that we look at. So the onus is on us as healthcare professionals to discuss that, and it is available through GMHS. The last quarter, just looked at the numbers there, with 55.
Yeah, and like, not like me to be controversial at all, but I think one of the things I'm observing is that where sexual health services are governed, have clinical governance from people who are interested in sexual health, who care about sexual health, I think there's an acceptance. I think when sexual health services are governed and led by people who do sexual health as part of a wider focus on infectious diseases, I think that's where we're seeing. And I would be interested, maybe I'll do something on clinicians and see why all the ID consultants are refusing to provide DoxyPEP and all the GPs, GUs and nurses are providing it. Because I think that's my observation of what I'm hearing from people. So it's important the community as well are highlighting this and not demanding from our service, but critically asking why things are not being provided. What do you want? You're on the net. Your name's on the
data. But yeah, first, thanks. That was a great and only like mildly threatening presentation.
I'm scary. I don't.
I suppose specifically clinically, we see a lot of the time maybe people who don't have a need for HIV PrEP because they don't engage in any penetrative sex, but that they would potentially benefit from doxycycline PEP. because they're engaging in oral sex and there's still a risk for chlamydia and syphilis, importantly. Did that come out in our data? Did we look specifically at maybe people who were engaged?
We didn't look, we didn't do any of it, but we might do it.
Yeah.
If the reviewers at STI come back and tell us to do it, we'll do it. If not, we'll do another paper. But I think that is it. But also, I think in January, like things fluctuate as well. So like there's not a point in time. So we need to be responsive and accessible. And we've had this conversation before about people who are on HIV PrEP probably don't need to be, but aren't leaving the service, because if they leave the service, they'll never get back in. So like, and I think I'd imagine in all of the clinics, there are people who are probably in monogamous relationships, non-sexually exclusive relationships, maybe having a low sex profile, but you know, but they're not going to leave your clinic because they know if they break up with the boyfriend tomorrow, or they decide to open up, or decide to go on holidays and have a gangbang, like that's actually very informal. But like, they're not going to be able to access the PrEP that they need, and that's a challenge that I look down at our colleagues from the sexual health program to think about how we do that. And Caroline's giving me a dirty look.
I know with our service, we kind of, you know, educate and like that. There's some people that just are like, this is, they have a hard time accepting, like, you know, maybe it's just old, like, anxiety around HIV transmission. So we kind of facilitate that. But for other people who are like maybe get into a new relationship, we kind of like, you know, look, you can come back to us, but within a few weeks, it'll just free up a space for somebody else. So just that kind of like, so they know that they can come email and we'll get you in within a few weeks.
That could form part of national guidance from the sexual health program. I think that would be very helpful, because again, it's a different type of patient, because you've already done all the education. You still have to do the bloods, you still have to restart them, but it's
like a return to
different,
service.
yeah, it's a different. And also, I think with DoxyPEP, again, it's dynamic. I said I hate the word STI burden, and I'm doing some work on it, because actually the prevalence is something, but burden, like for some people they get chlamydia and they're like, sure, it's grand, I'll get, you know, and for other people it's a big impact on their life. It may impact their working life, it may impact many other things. So I think looking at it as a dynamic intervention that can help some groups and individuals and maybe isn't as helpful for others. DoxyPEP is not the evidence does not support, I mean, that's the wrong language as well, but there isn't strong evidence around the use of DoxyPEP for people with vaginas. And that's basically because Fiona Lyons ate me for this one day, and then I defended myself. The research itself is inherently sexist and transphobic, because we haven't really looked at women and trans masc people. So you know, there is one study that people keep going to, but the adherence was very poor, so of course it wasn't going to work. But so I think I don't know what the official HSE guidance will be, but in the interim guidance and in the BASH guidance, despite that lack of evidence, we have stated that, you know, it may be useful, and particularly in issues of sexual assault, etc., to offer DoxyPEP. Okay. Thank you.
Thanks, Ron. Next up, we have Derek Brown from Bandit, who's going to be speaking about ChemSec and the good feeding.
Good morning, everybody, and thanks to the Gay Health Network and the Gay Health Forum for allowing me to put the issue of intimate partner violence among gay and bisexual men on the healthcare agenda. Two things struck me while I was sitting there waiting to come up. One, that I was desperate for we, but also 30 years of Gay Health Network. I came out 40 years ago in 1985. And McQuillan, I remember coming into the gay youth group, as it was at the time, in the Hirschfeld Centre, telling us about HIV. I don't think it was even called HIV at the time, and educating us about how to have sex with each other, how to put on condoms. Just to give you a bit of context, I lost more than half of my friends from back then to HIV. Can you imagine how devastating that was? 4 years ago, just before I started work with Men's Aid, 1 month before my 56th birthday, I was diagnosed with HIV. It was a shock. I was diagnosed within 8 weeks, and I went on treatment immediately. 11 weeks and 4 days after infection, I was undetectable. That is the success of the work that we've been doing for the last 30 or 40 years. That's incredible, incredible stuff. And thank you to my friend for pointing out that those of us who are undetectable pose absolutely no threat sexually to other people. So we're the best people to have sex with. Yeah. Insane. Yeah, technical bit. What do I do with the press? Do I press on the middle?
No,
Thanks. Other. I can get my toast to pop up together in the morning. So just to give you some background, since I've been working with men's aid, I've been collaborating with Graham Ryle, who many of you know. He has spoken here at this forum before. This is, I was meant to do it 2 years ago, for the last 2 years, in fact, when I was sick. So it's great to finally be here, third time lucky. But what we do, we deliver a 3-hour seminar on chemsex from a non-judgmental harm reduction approach. So important that we stress that. There are 2 clear approaches. My remit, of course, is intimate partner violence. So I cover the chemsex and intimate partner violence and coercive control among gbMSM section, and Graham looks at addiction and the psychological impact of chemsex. He's amazing, and you know that, and it's fantastic to work with him. So in terms of the no judgment, a lot of the work we do is with Garda Síochána, and we work around the country, and the demand for the workshops has increased dramatically. We did 5 in 2024. We did 7 in the first half of this year, and we've got more in the pipeline. But in terms of no judgment, it's, you know, generally, it's kind of like thought that the impact of chemsex on those who engage is understood to be negative. But most men who engage in this activity can continue with their lives and actually don't become addicted. And we have to remember that. Most men engage for reasons of isolation and loneliness, and become because they feel displaced from the existing social LGBTQ scene, or as one of my Trinity colleagues called it once, the le je peux quoi. I think it's so much nicer. So therefore, engaging in chemsex can have a positive impact too, because friendships are developed, trust is made, and information about reducing harm when engaging in drug use is shared. And that's important, you know, all too often there's a negative slant put on this. And while there are, of course, risks, we have to bear in mind that there is a positive angle too. So just in terms of having a common understanding of sexual violence, I go back to the Central Statistics Office 2022 survey, which basically states that sexual violence is understood to be any act which violates a person's sense of personal dignity. But how can a person understand that their personal dignity has been violated if they have no sense of that? And that's something, certainly as a gay man, when I look back 40 years, you know, when you're a member of the LGBT community, your sense of personal dignity is attacked from the moment you start socializing in the world around you, because you're made to feel that you are in some way less. I mean, I remember as a kid being told I was evil by an adult. Imagine that. That's a memory that is stuck in my mind all my life. So understanding what they mean by sexual violence, understanding that to understand when we've experienced that requires an understanding of our own sense of personal dignity is extremely important, and that can be challenging for members of our communities. Then in terms of understanding consent, and I just thought, you know, the importance of coming to events like this is, it cannot be, you know, understated. Listening to the doctor from the Gay Health Men's Project talking about Carlos's story, that really resonated with me in terms of the work that I'm doing. And it is fantastic to see the response that that young man got, the services that were available. I learned that today, and that's important information for me, and I'm sure important information for all of us. Anyway, in terms of consent, one key aspect of remaining safe during chemsex party. Do we all understand what chemsex is, by the way? Great. It's the issue of consent is understanding that what that means in the chemsex context. In general, consent is understood, or that consent to engage with sex means that there is an agreement between the people who are having sex with each other. This has been given freely, without coercion and without the influence of drugs or alcohol. So in a chemsex situation, we're kind of like, that is a difficult situation. It's also understood that consent may be withdrawn at any time, and in short, consent requires rational thinking. Again, in the chemsex situation, how does that work? So what are the factors that affect rational thinking among gbMSM in general when it comes to sexual practices? When is consent given? But also just ask the question, is consent relevant in the chemsex arena? We always have to be careful not to be making assumptions. So I think, you know, for me, it's like, I'm not standing here giving out data and giving out answers. What I'm simply doing is explaining to you what is emerging from my work at Men's Aid, what is emerging from this work, and sort of adding to the conversation, asking some questions that maybe we can start exploring as practitioners and as members of a community. So what the research says fundamentally is that the high prevalence of intimate partner violence, victimization among gay, bisexual men and sexist men is associated with substance use and sexual risk behaviors. Therefore, we see a correlation and a connection with chemsex in relation to intimate partner violence. Intimate partner violence rates are disproportionately high among sexual minority populations. And again, we know that from all the studies, and we know that from the Irish study 2022. And most types of intimate partner violence perpetrated among gay, bisexual, and sexist men is linked to internalized homophobia. That's something I think we need to really start exploring too. This guy, Rob Stevenson, he came to Dublin in June 2022 after I started work with Men's Aid, and he's quite prolific in writing in this area. He's an English guy working in the United States. He's incredible. He's amazing, and he's been a wonderful support to me. But we have had lots of conversations about this issue of internalized homophobia and the role it plays in so many issues that exist in our community. In terms of the work that I've been doing, the risk factors for domestic violence can be general, can be prominent, but also specific to the LGBT context. Substance use and misuse is huge. You tend to see alcohol among women and illicit drugs among men as being the problem substances. Mental health issues, you just have to look at the being LGBT in Ireland report from last year. And it's actually what shocked me, and I'm sure you, was the findings are worse than they were in 2016. So what's going on? What is going on with our people? You know, what's happening? So it's kind of like, for me, there's a lot of questions coming up at the moment. The diactic power struggles, where there's, you know, two major differentials. The most common one is, for men anyways, one tends to be older than the other. You know, my colleague Carl Heller, former Garda Chief Superintendent, works in Dublin House. And what he's been telling me lately is that what he's noticing this year in particular is that when men in relationships with men come for support, they come when things have gotten extremely violent, physically violent. It's extreme. And also what we're seeing at Men's Aid is a significant increase in suicidal ideation. Again, questions. Why is this happening? What's going on? So anyway, I never like to kind of like throw a problem out there. As my Jewish grandmother would say, a problem is never as permanent as a solution. She wasn't really Jewish, it's just... So what can we do to support gbMSM who engage in chemsex? So it could be argued that consent does not only require free choice, but also requires information so that informed decisions can be made. As an educator all my life, of course, I come down on the side of education. Research suggests that intimate partner violence screening and prevention programs may reduce substance abuse and sexual risk behaviors. So there's maybe some jobs for us and some research for us in the future. But through education, I firmly believe, through education and training programs, we can address these issues and build the capacity of gbMSM to make informed choices about their sexual engagement and have a clearer understanding of the issue of consent. And I think it is a conversation for us to start having. I just want to, in terms of seeking support, the help is out there. There is a lot going on. And this is from Porg, your organization, Gay Network, will put all this together and it's on your website. We give this out to everybody because there's so much information about men's aid there. But it's great to what I've learned today about the Gay Mental Health Service and what they provide, that holistic wraparound services for somebody who has experienced sexual violence is fantastic. And I'd like to learn more about that. References are there. And that's why thank you very much for the opportunity.
Thanks, Eric. Next up, we have Alicia Maduha from the Sexual Health Centre in Cork, and they're going to be speaking about outreach in Cork's cruising sites.
Good morning, everyone. Thank you so much for having me to present on our innovation in the Sexual Health Centre on using bed boxes as condom dispensers. So my name is El Shaddai, and I realize many people don't know how to pronounce it. You can work, oh, that's fine. You're forgiven. Now, all right, so this is our mission in the Sexual Health Centre to firstly, to provide comprehensive, up-to-date information about sexual health, well-being, and sexuality, offer a safe space for individuals to express concerns without fear and get non-biased answers, help sexual health and sexuality to be seen as a normal part of life, then encourage a nationwide acceptance of sexual health as an integral part of life. So, I don't know what's happening here. Next slide, please. Okay, so this slide is just to highlight some of the services we provide in the center. We do HIV testing support, counseling services, fast track cities, and so on, drugs and sexual health. There are a lot of services that we offer there. Then just to give a bit of the background of our work in the cruising sites. So cruising sites are public environments where gay, bisexual, and men who have sex with men meet to engage in sexual activities. This could be in car parks, this could be in the woods, or toilets or whatever. Then these sites have been shown to play a part in HIV and other sexually transmitted infection transmission. So by making condoms and lubricants readily available at these sites, gbMSMs are better equipped to engage in safer sex and reduce the risk of STI transmission. So, bed boxes were selected as a discreet and practical method for distributing condoms and lubricant in public cruising sites. So their familiar appearance allows them to blend naturally into the outdoor environments without drawing unwanted attention, which helps protect the privacy of users. Then the design also provides a weather-resistant and tamper-resistant way to store sexual health supplies, ensuring they remain clean, accessible, and usable. This subtle approach supports harm reduction by offering resources directly where they're needed, without also drawing attention from non-users, and also without stigma and barriers or any barriers. Next slide. Then in terms of implementation, so this is kind of old. We installed like 4 bed boxes at the site. So there's one popular cruising site in Cork. So 3 of them, we use them to put in condoms and lubes. Then one of them is used as a bin, just to manage the used trash. So in terms of contents, we fill them in once a week, and each bed box is able to contain 160 condoms and 120 sachets of lubricant. So there's a QR code, as you can see from the picture, which is affixed to each bed box, linking directly to the SHC website. So We check them every week and restock them every week. And also health promotion officers, actually 2 people go to the cruising sites. They go there and engage in brief conversations and signposting clients for relevant services as well. So in these sites as well, also distribute SH24 kits to clients who need them. Next slide. So as of, because we started this project late last year, we distributed 21 STI test kits so far, and then approximately for an average of like 480 condoms and 360 loops are distributed each week. So it just shows how busy the cruising sites are. And we reached out to 85 gbMSM in 2024, and these are most like the most frequently discussed topics include PrEP, HIV testing, U equals to U, STI screening, LGBTI support and counseling, chemsex harm reduction. So we also also book clients in for testing as well. Next slide. Then we also use geolocation apps like Grindr, Scruff, Growler. So as soon as we arrive to the cruising site, we just like highlight our presence there, like on our profile, so that people are able to engage with us, and also can also signpost them for services from the geolocation apps. So this approach is particularly valuable for individuals who may not feel comfortable accessing traditional health services, such as married men or others who keep their sexuality hidden, or their sexual activity hidden, who may not be able to order SH24 test kits to their home or purchase condoms online as well. Next slide. So this is some of the feedback that we got from the cruising site. It was amazing that like the day we installed the bed box, we're just worried like how people are gonna know like this is the use of the bed box. But within 30 minutes of putting up the bed box, we just received a message on Grindr just saying thank you for the gift, which was really amazing. Please. So challenges and solutions. So one of the challenges literally because like people are just throwing out like condom wrappers and used condoms everywhere. So since we installed the bed box which represents a bin, we just labeled clearly that this is a bin. Some people are actually using the bin, and we health promotion officers, we go there just to like to take out the trash and sometimes to clean. As you can see, one of my colleagues is cleaning the environment. So one of the solutions was just putting up one of the bed box as a bin. So also like sometimes also the other challenge is just like when engaging at cruising sites, it starts as a sexual solicit, then we manage to turn the conversation into like a brief intervention. So it really works, and now also there's like familiarity and trust building among the users and also the health promotion officers. Thank you so much.
Yeah, so I have a question. How do you determine, these sites? Like, you ask people in the community, where do you usually go for cruising?
Yeah, so like the first thing is just like we talk to our clients who come in the center, and also there's a website. I think there's an app called Sweat as well, where people are able to like to talk like where they are, like they can mention the cruising sites. So that's how we came to know about the cruising sites. But anyway, some of them they are like well known because they've been very active since the 1980s, early 2000s. So like they're well known.
Yes. Just one more, if it's okay. So I suppose it's like psychologically, if a person would like go for cruising, like they would want somewhere discreet. So you think that by doing this bird box, like it is like people mightn't go there anymore because it's not very discreet for them, or something, they would be afraid?
So I would say, if I got you correctly, like people are very discreet when they're using cruising sites. And initially for us, like one of the challenges there is just like there's no conversations. So like people don't really want to talk, but we realize also like there's use of signs. Like people be like set signs like, I'm interested in you, then you're like, I'm interested in you too, then let's go and do things. So it's just like sign language. But like also with time, with us going there, like people ended up knowing that we're from the sexual health center, so they're able to come to us and just ask questions. So for us, we don't like start the conversation. We wait for them to start talking to us, then we respond to them. Look, we're from the sexual health center, providing 1 or 2 or 3 things. Yeah. So it remains discreet, and like it's just like people know us. They know us on the geolocation apps now. They know us on the prison sites as well.
Thanks so much for that. Yeah, I mean, I've been interested in this since it started. I'm just wondering whether any discussions have taken place with the Gardaí, because I think intermittently in Dublin we have issues of police harassment at cruising sites, and kind of the awareness of these. I used to do this kind of outreach when I lived in London, and what we actually found with Terence Higgins was that we went to a certain part of the heath, and did kind of outreach in condoms, and actually we ruined cruising, but it continued because cruising just moved somewhere else, but people still knew that there was access there. So I think that's something, but I'm just interested with whether there's been a pledge from the Gardaí not to harass people in these areas.
So engagements, we have done it higher level. I wasn't involved in the engagements anyway, but like from what I heard, there are like some cruising sites where they're frequented mostly by the general population. They would report to the guards, like people are using these sites for this and that and that. That's when the guards would go there, like, you know, like just try to stop it. But the one in particular that we put up all these, you know, like red boxes, there is no much of like the general population going to that site. So we didn't hear any troubles with the guards or anything.
Yeah, I just thought it's a really interesting and creative way of, I suppose, providing condoms and lube to people who do need them. We had an anonymous letter into our service a couple of months ago about wrappers and used condoms and lube being left around cruising areas in Dublin, and the person who wrote the letter was specifically concerned about the negative attention that might attract to the community. And so I think as well, having a disposal kind of mechanism is really important, and really, so I just like, well done. I think it's really good work.
Alan's just had to step out, so I'm going to take over from here. For those who don't know me, I'm Keith, and I'm on the board of GHN. I'm a banker by day. Banker with a B. And over time, so just for this, to respect all speakers for the rest of the next hour between now and lunch, can we just restrict Q&A, the actual Q&A section, and then everyone can have lunch at 1 p.m. But delighted to welcome Dr. Robbie Lawler, and next up about the shift.
Hello everyone. I didn't know Cork had a good cruising, so I think I'm booking a trip there soon. And I think it just shows how cheap interventions can really work, especially for underserved communities. So I just really want to say thank you for all your work. Also thank you to John Gilmore for that DoxyPEP study. I was planning on coming here fighting to say, you can take my DoxyPEP with my cold, dead gay hands, because no one is taking this away from me. I haven't gotten STI in 1 year. And it's really down to that. And I sourced it from a dodgy pharmacist in Brazil. But no, so it just shows I want to take it effectively, safely. And as we say, we really do care about things such as antimicrobial resistance. So that's why we need guidelines and good connections to our clinicians. So very happy to hear what's happening in Gay Men's Health Service too. So my name is Robbie Lawler. When I am not busy experiencing the burden of living with an STI, I'm also a postdoc on the SHIFT study. The SHIFT study, I'm happy Liam pointed out, means sexual health in Ireland, factors in transmission and prevention. SHIFT is slang for KISS in Ireland, and because this is an evidence for policy study as well, hopefully the data generated through this research can help shift some policy. Also on this research is Dr. Santi Garcia, who can't be here, which I'm going to kill because the results that I share are his. And also Dr. Chris Noon is the principal investigator who's hiding at the back. So if there's any really hard questions, you can give them to him. This research really came out from a call from the Department of Health, who we are collaborating very strongly with. And basically what the Department of Health wanted to know was, what are the underlying factors for Ireland's current STI rates? So we wanted to look at primarily three, which was young people aged 18 to 25, gay and bi men, and migrant communities in Ireland. But with discussions with our PPI, which I'll talk about later, and with discussions in the internal group, core research group, we decided to expand this to transgender people and gender diverse people too. So we can talk a little bit about that too. And it's funded by the Health Research Board. So the context, look, you're probably sick of seeing these graphs ad nauseum. I am too, but basically we are not close to reaching our World Health Organization goals. We are not where we need to be with current STI rates in Ireland. And with the HIV rates at the bottom here, we had around 173 new HIV diagnoses in 2023, this was. Also on this point, I want to make a point that 553 transferred their care here to Ireland. That means we have so many gorgeous people who decided to make Ireland a home. And the reason why I always want to state this is because when we talk about HIV, we talk about trying to end new HIV infections, and we forget about the stigma and discrimination, and we forget about the thousands of us living with HIV in Ireland and our quality of life. So although I do show this in terms of STI rates, I also do want to always acknowledge the thousands of us living with HIV who are often forgotten in these discussions too. So who is part of the team? Sorry, this is just an introduction, by the way. It's kind of boring, and we don't have too much results. I will share results, but this is an ongoing study, and I'm here to try and open the floor up to help from the community too, to make this as effective as possible, this study. So we are led by a steering group, and it's full of clinicians, researchers, policymakers, and community groups, people working at NGOs. But also we work with, and most importantly, in my opinion, is PPI panels. I'm biased because I'm PPI with the European Community Advisory Board and HIV clinical trials for cure trials, vaccine trials, and salvage therapy trials. So I understand the importance of community in community research, which again is often left out. But they have been so invaluable to this research, I cannot explain. So as we can see from the steering committee, we have some of the best minds in Ireland working on this, but yet the PPI panels have been giving us way more information from the grassroots perspective. So from everything from the ethics application to our interview protocol, to our recruitment strategies, they have fed into everything and we would be lost without them. So I just want to give a special shout out to that. And I'm giving reflections on the National Sexual Health Strategy later. And a big part of that is kind of doing more community research, especially for marginalized voices. And I want to push now that I'm delighted the Department of Health required PPI, strong PPI, and I hope that continues when we do look at work with sex workers and the trans community, for example. So what do we want to do? Well, we're working with policymakers, some are in this room. I think a real strength of this research is that we are collaborating with the Department of Health throughout the lifetime of this project. And it's not often academics get to talk all the time with policymakers. I think this also feeds into what the National Sexual Health Strategy is trying to achieve. And I really, really want to encourage that. It's been amazing and helping with guide this research too. Strong PPI panels. I have 4 from each cohort. So trying to get 12 people in a room at once is a nightmare, let's say. But I handpicked them out because I wanted people who were interested in sexual health policy and had good networks to help disseminate the research too. So I was quite purposeful in that. So there's 4 work packages. The first was a systematic review of STI trends and drivers. So we really want to understand the global predictors of trends in diagnosis of gonorrhea, chlamydia, syphilis, and HIV. Why we chose those 4 STIs in particular is with conversations with our advisory working group. They're the ones of the biggest concern to global epidemiology, to the HSC, and they're the 4 STIs that we pick up through SH24 as well. So that's what we really focused on throughout these different work packages. The second one, which will be done soon, next year, will be secondary analysis of Irish quantitative data. So we'll use Healthy Ireland data, grown up in Ireland. We have some Ipsos data, thanks to people in the room for providing that. And I have EMIS in question marks, because anyone who's ever tried to access that EMIS data set will know how difficult it is and how much you just want to throw yourself off a bridge, even trying to get access to it. So whoever done that previous one, I will be talking to you. Hopefully we get that soon. Oh. These are both of the quantitative one. I am a qualitative researcher through and through. So I'm really excited to discuss later the qualitative interviews with young people, gbMSM, trans people, and migrant communities. And we want to just understand the evolution of people's sexual health behaviors. how these have changed over time, what external factors have affected their access to STI services or sexual health services or condom usage or PrEP access over time. Was it just life issues? Were they external issues like the free contraception scheme, for example? So what impacted these? So that we're doing a life course approach. And then last but not least, work package 4 will be participatory systems mapping of STI transmission. So we're bringing all the stakeholders we talked about into a room, and we're going to be talking about all the different components of the STI ecosystem, from the individual up to the institutional. And then together, we're going to work out the positive and negative associations for what is resulting or affecting STI transmission in Ireland. Hopefully, with this mapping and with the results of each of the different work packages, we can come up with really solid policy recommendations and work with the Department of Health to make this a reality too. So for the sake of this, I don't know how many minutes I have left, we'll talk about the systematic review. Now, as I said, I did not do this, so if I'm reading up my screen, please blame Santi for not being here. But the research question was, what are the global predictors of trends and diagnoses of gonorrhea, chlamydia, syphilis, HIV over the last 10 years? If you really want to look through how we've done this, our protocol has been uploaded to the HRB Open Journal. So we recommend reading that, it's riveting. But we are already writing our paper, so we have preliminary results, which we will show you soon. But basically, for systematic review, we wanted to look at trends and incidents and what causes these. So when we talk about predictors, different socio-demographic information we need, like sex, migration histories, condom usage, so from the behavioral to the individual. That's what we were hoping for. So if we were able to get all this information from around the world with strict criteria, maybe we can talk about what's happening around the world and is this happening similarly in Ireland. Let's just talk a little bit about what the criteria for this research was. So we wanted studies that imply statistical trend analysis, reported predictors of targeted STI diagnoses, which we talked about earlier, that had incidence data, and that had national representative population samples. And these are all the databases we used, and we used citation mining. So from this, Santi got around 13,000 hits. And together, over a few months, he'd done the Trojan work, we got it down to 20 studies. Because many just didn't reach the strict criteria that we had. We looked at the grey literature. There was around 68 grey literatures that we looked at. Only one had any kind of statistical information that we could use on certain criteria. And I think that was UNAID's most recent report as well. So we won't go too much into it. The results are disappointing for everyone, right? We wanted some really, really good indicators of why are we seeing an increase, a global increase in STIs. And the problem is there's not enough data that's collected that we can accurately give predictors on. Liam mentioned earlier about the needing for granular data if we're to make any kind of a trend analyses, but it's just not there. When we talk about epidemiology data, we get male, female, country, and probably that's it. And sometimes not even male, female. It is quite shocking, to be honest. It's the same with grey literature. So if we do reports, there's absolutely no data or very little data that we can use. For HIV, it's quite interesting. We see males present greater numbers of HIV diagnoses than females in this cohort, but we know there's nuance to that. So we know in sub-Saharan Africa, for example, women and young girls are more likely to have diagnoses. And the age range is widening, and that people in their 20s and 30s are more likely to be affected by HIV too. Interesting studies like in China, women over the age of 50 are more likely to have HIV, and they've just assumed that it's probably due to after post-sterilization. They didn't think that condoms are necessary. However, that wasn't collected in data sets, that's just inferred through external sources. So that's why we can't include these kind of data in the research. 4 studies only provided explicit information on testing rates. So why is that a problem? I can see people in the HPSC probably racking their heads on this. And if we see an increase in STIs, but we don't know how much testing is done with it, we can't really tell is because there's more testing as testing frameworks changed. So it's very hard for us then to make inferences from this data as well. So we really need to have really good collection of data. Again, if I can talk about the National Sexual Health Strategy, I'm running into my reflections that we'll be doing later on today. But if we are to collect granular data, what are you actually going to collect? And who's part of making those decisions on what's going to be collected too? If we really do want to look at trends over time, we really need to look at the behavioural, the structural and the social. And 3 studies only adjusted for COVID-19 disruptions out of 9 that looked over that data set. So again, it just shows you how bad the data is collected, and so how hard it was for us in the systematic review to really come up with any really good conclusions that we can really work with, other than we have to change how we collect the data, which is probably no surprise to many people here too. So we need more rigorous and comprehensive standards in data reporting. We need to not just see people as white cisgender or their nationality. We need to really get granular data to make any kind of predictions. Without predictions, without data, we don't have campaigns, we don't have interventions. We won't reach our targets. Very hard then to interpret STI trends related to behavioural, structural and social, as I mentioned as well. So I hope I've done Santi proud with the systematic review. Hopefully I haven't bored you too much because it is quite a boring process, but I think it's important too. So this is my baby. This is the qualitative interviews. Again, this is important. We really want to get 20 interviews per cohort. So if we're game by men and many sex of men, young people, age 18 to 25, trans people, and people from the migrant community. We're using a critical realist approach because we want to look at the underlying factors from the behavioural, institutional, structural, access barriers. And we really want to understand different elements of people's STI prevention strategies. We're using a maximum variation sampling. That basically means we need as many diverse voices represented in this research as possible. So hopefully we can find common threads among these barriers or accessing, what's encouraging people to get tested or to get DoxyPEP or PrEP, for example. I didn't talk too much about our logo design, which is probably confusing to people at the moment. Normally I should have put those in, but basically, can I say it? There's no better representation in Ireland of protecting yourself or someone else than an umbrella in the rain, right? And only a creative designer would notice that the silhouette of an umbrella is a condom. And also the QR code is a condom wrapper, if you see it, so it's pretty cool. This is going to go up. We have quite a robust recruitment strategy, but we need your help. It's all over Ireland. We need as many diverse voices as I said. And when you see this, please, please, please share. If you think someone's a good fit for it, please share with them. This is going to be out next week. So that is my plea to you. We will be updating you of the SHIFT study as we go along. Many of you are part of the steering committee, so I look forward to continuing working with you all. And yeah, please just support the work. And I'm really grateful for everything. So thanks very much.
No problem. Let's hope people continue to contribute to the shift.
Exactly.
So next up we have antibody response to Mpox by John Moore.
Hi everyone, my name is Joanne Byrne. I'm an infectious diseases doctor at St. Vincent's Hospital, and I'm also doing a PhD at the moment, exploring the immune response to Mpox infection and vaccination. So I'm delighted to be here today to speak to you and to be able to share some of the results of the research studies that the community here in Ireland has been involved in, and perhaps even some of you here in the room.
Nice.
Next. Right. You're okay. full screen,
Yeah.
that's fine, I think. Everyone should be able to see it, perfect. Okay, so for some background, so mpox is an infection caused by the monkeypox virus. So this is very closely related to smallpox, which was eradicated decades ago. And until 2022, mpox was a neglected tropical disease. So a very small number of cases in limited outbreaks in West and Central Africa. What we saw in 2022 was this unprecedented outbreak globally with over 100,000 cases. And these predominantly or disproportionately affected gay and bisexual men who have sex with men, and particularly those living with HIV. If we look at the right-hand side of the screen, you can see an epidemic curve. So those bars represent the number of mpox cases per month. So this data is from Ireland, but it's actually very similar to what we saw in Europe and what they would have seen in North America. We saw this really rapid rise in 2022, a rapid decline, then very low numbers until the end of last year and start of this year, where the numbers have started to increase again. But if we look at that rapid decline in the curve, that was brought about both by behavioural change within the community here in Ireland, and I think Ireland has been noted on a European level for having a really remarkable response to the mpox outbreak, but also from immunity. So, next slide. Thank you. When we speak about immunity, it can either be gathered from infection or from vaccination. So the mpox vaccine was actually a smallpox vaccine. And this had never previously been studied for mpox prevention, but in the context of the global outbreak or the public health emergency, it was given emergency authorization. So it was known to be safe and it was known to be immunogenic for smallpox initially, but really very little was known about its long-term protection or its long-term durability. And we saw really excellent uptake in Ireland. These are photos from the UK, but we saw very similar queues at the mpox vaccine clinics in Ireland. The increasing numbers of mpox infections actually relate to a large number of breakthrough infections in vaccinated people. And this has really raised concerns about the immune durability and has prompted a lot of discussions in the community about potentially needing booster vaccines. So this left us with a lot of research questions to answer, but the first question we had to answer was how do we actually measure immunity? So mpox was a neglected tropical disease. No one really had researched it. There was no commercial lab test we could buy or get in order to measure antibody levels, so we had to develop our own one. So to do this, I took about 400 samples from 300 individuals, either with a history of mpox infection, a history of mpox vaccine, or negative controls. Those negative controls were also sampled from our HIV and PrEP clinics. And we measured antibody titers to 13 different proteins. And through doing this, we were able to develop our own lab test that could measure immunity to infection and to vaccine, and also to be able to differentiate between them. And we published this earlier this year so that other research labs around the world can actually copy our protocol and be able to use it as well. So next slide. So then, using this antibody test, the first question we wanted to ask, well, what is the immune response to infection and vaccine? Is it different, and how does it change over time? So the graph on the left there, red is infection over time, blue is vaccine over time. And it was quite interesting. So the individuals who had infection had significantly higher antibody titers than those who had vaccination. We then looked there on the right at the vaccine over different time intervals up to about a year. What we saw was initially a very strong response, so almost 100% had a detectable antibody response, and then this decreased to just about 50% at a year, but these were quite small numbers. Next slide. So we wanted to look at this in more detail in a larger group and for a longer follow-up term. So we sampled 135 individuals at 2 years, either post-infection or vaccine. And importantly, 25% of those were living with HIV. Just to mention, all of those living with HIV had an undetectable viral load, and they were all on antiretroviral therapy. So what we saw was this is a snapshot of immune responses 2 years post-exposure. Green is infection, significantly higher than blue, which is vaccine again. So almost all of the infection groups still had a detectable antibody response 2 years later, but just a third of the vaccine group had a detectable antibody response. And if you were living with HIV, you were significantly less likely to have a detectable antibody response, so actually 82% less likely. So we just published that work last month. Next slide. So We were then able to use statistical modeling techniques to really kind of model how do these antibody responses change over time. So I won't go into a huge amount of detail, but basically, as per this model, in this population, which I will say is predominantly Caucasian, all assigned male sex at birth, the antibody titers post-vaccine became undetectable for the average person 15 and a half months after vaccine, whereas for infection, it's a very small group, but the confidence intervals, that grey shaded part, with 95% confidence, we can say they remained detectable for the duration of follow-up. So this waning antibody responses really, again, potentially supports need for booster vaccines to increase antibody responses. But next slide. What's still unanswered is, do the high antibody titers actually protect you from Mpox? We haven't been able to fully answer this question yet, but this is just one case that gives us a little bit more information and is quite interesting. So this is a gentleman, he's one of my research participants, and he's very kindly given permission for his image to be shared with you today, as well as for publication. So he had been vaccinated for Mpox over 2 years prior. He presented to clinic just for a routine clinic appointment, and we noted that he had this very unusual looking spot on his nose. We didn't think Mpox straight away. I'm not sure if anyone in the room would think Mpox straight away, but we swabbed it, and it was positive for Mpox. So we had no other lesions, systemically very well, and completely asymptomatic apart from this one lesion that resolved within 2 weeks. When we went back, so he had actually taken part in our research study just about 3 months before that 2-year data that I showed you. He had actually had a really high immune response to vaccine. So he was in the top 2%. So this is the first case that we know of that's been published in someone who's actually gone on to develop Mpox, who's had a proven vaccine immune response. So we hypothesized that that immune response, although it didn't prevent him from getting infection, it certainly modified his disease away from severe systemic disease. But it highlights a few interesting things. The first being, we need to maintain clinical vigilance. Breakthrough Mpox in people with robust immune response likely presents in atypical, subclinical, or even asymptomatic ways, and that is unknown yet about asymptomatic Mpox. But it also really reinforces the uncertainty we have about what actually protects us from Mpox following Mpox vaccination. And if we're just to go on antibody titers, booster vaccines may not actually have a role. So next slide. So we're currently running a clinical trial called the Mpox Vax study, and this is to look at those questions in more detail. So we're looking for individuals who have not yet been vaccinated for Mpox. It's run across 6 hospitals, so 4 hospitals in Dublin and then in Galway and Cork, and we're following individuals up for a year after vaccine to look at their immune response, to see if we can really identify what clinical factors impact on antibody levels waning, but also to look inside the lab against a real viral challenge to see, can we predict if antibody titers can actually prevent against infection. So if anyone is interested or knows anyone who has not yet been vaccinated for Mpox, you're welcome to contact mpoxvax@ucd.ie. So what lies ahead? I've only spoken about the Irish response to Mpox vaccine, but Mpox is currently causing a public health emergency in Central Africa at the moment with thousands of cases. We have been given funding on a European level to work with our colleagues in the DRC, in Uganda and Tanzania to examine what the immune response is to the Mpox vaccine there. And we'll be able to share our data from Ireland directly with this population to see how the population differs. As I mentioned, we don't fully understand the significance of the antibody titers' role in protection. So is there a B cell component or a memory T cell? These are long-lived memory cells that could potentially protect you. And then finally, which I've been asked a huge amount in clinics from patients, is when are the booster vaccines coming and when can they have one? So it is absolutely great to work in an environment that's so pro-vaccine, especially given everything that's going on at the moment. But there is no current evidence, and the National Immunity Advisory Committee has still not recommended a rollout of booster vaccines. So we are running a clinical trial looking at booster vaccines. It hopefully should be open in the next few months, in the early next year. So again, if anyone is interested in being involved in that study, you're welcome to pre-register your interest again at mpoxvax@ucd.ie, because hopefully that will be able to answer that important question. Last slide. And finally, I'd just like to take this opportunity to thank everyone in the community who's been part of this research. Without patients giving their time, their samples, and committing to follow up, none of this research would be possible. So we really are grateful and thank you very much. So.
And that was really interesting. Well done, your great work. So next up, you have Mark Doyle, who's going to give a quick discussion on navigating disclosures and service gaps. Mark in here. We will move on to our next committee session. Is young LGBT people, and we have Kyle Fu first. Who's going to discuss sexual behaviours, LGBT absence, and from Gen Pop survey.
Who was expected, Kyle Fu. My name is Andras Koto and I'm his supervisor. Sending you his best regards, but he's having the clinical induction day today, so that's why the supervisor had to jump in and give this presentation on his behalf. I would like to share you some data from a general population health study called the Health Behavior in School-Age Children, which is a cross-cultural, cross-national general epidemiological study on the health and well-being of adolescents. And now I would like to share you some data on the sexual health and well-being of sexual and gender minority youth compared to their non-minority peers. I'm sure we have already discussed, and I'm sure everybody in the audience are very well aware of all the reasons and the ramifications of the sexual health disparities between LGBTQ+ and cisgender heterosexual youth. So I'm not going into details, just wanted to highlight a very recent research by Dr. John Gilmore and his colleague, which was published in the Journal of Nursing Sciences. And he and his colleagues highlighted that in a scoping review, that while there is ample evidence on gay and bisexual men and other men having sex with men, all other LGBTQ+ groups are underrepresented in research. And with HBSC, we quite luckily had the chance to look a bit more granular into the health and well-being of the different subgroups within the LGBTQ+ community. And another thing which I wanted to highlight is that it seems that sexual and gender minority youth are more likely to be engaged in sex and more likely to be engaged in risky sex for lots of different reasons. And one reason is that they are exploring their sexuality, and that's a way to establish their identity. But unfortunately, we also know from research, especially from research of Professor Elizabeth Sabik from Vancouver, that they also get engaged in sex and risky sex because it also serves as a kind of stigma management process. And it might also serve to conceal their real identities or to avoid bullying and harassment. So we wanted to test in an iris sample of adolescents whether these well-established differences and disparities in sexual health can also be found in LGBTQ subgroups. We hypothesized they are, as we know very well from the literature, and we also wanted to compare the different subgroups within the LGBTQ population. We have some data that, for instance, there are even significant statistical differences between heterosexual and mostly heterosexual people. But if we are going to more detail, pan and omnisexual people are usually at higher risk than even bisexual. And we also very well know from the literature that when we are comparing lesbian and gay to their bisexual counterparts, there are also statistically significant differences. So we use data from the Health Behavior School-Age Children study, which was established 40 years ago, and it has been conducted in every 4 years since then in a constantly growing number of countries. Currently, the study is involving 51 countries who participated in 2022 data collection. Unfortunately, this doesn't mean that we have data on LGBTQ children from all these 51 countries. The questions on gender identity, birth registered sex, and sexual orientation are all optional questions, which a handful of countries opted to use. And quite luckily, Ireland was there. If you are if you're interested in the HBSC, you can find the national reports and a series of international reports on different topics, including sexual at these websites. And just to give a bit of methodological background, this is a self-completion survey. In Ireland, it's done either by paper and pencil questionnaires or online questionnaires at the discretion of the schools. And the core populations are 11, 13, and 15-year-olds. Also in Ireland, the 9-year-olds and the 18-year-olds part of the sample, but the sexual health questions are only asked from 15 and over. So now we will concentrate on the 15 to 18-year-olds. And it seems that so far this is the largest sample size research which you are hearing about today. There were more than 2,500 adolescents in the sample. And I didn't prepare a descriptive stats table, but just to give you an insight, around 20% of young people are reporting a non-heterosexual identity, and around 5% of the sample belong to gender diverse groups, so not cisgender boys or cisgender girls. We have used standardized questions to measure have they had sexual intercourse in their life, if yes, at what age? And we separated those who had sex before 14 and older. And also from the sexually active children, we not just asked their age at first sexual intercourse, but we also asked whether that the last intercourse they used condoms, pills, or other methods, or they weren't engaged or they didn't use any form of protection. We also used two standard questions to measure their birth registered sex and their gender identity. And in the gender identity question, they could also highlight that they neither identify with being boy or girl, or they use another gender descriptor. And using this two-step approach, by first measuring the birth registered sex and then the gender identity, we could also separate transgender children. We also asked young people about their sexual orientation, and based on literature and based on a 700 pilot study with sexual and gender minority children, we also included mostly heterosexual, and we also included the bracket where they could provide another sexual orientation descriptor. And quite luckily, we found a large variety of responses from which we could also make meaningful other groups. For instance, pan and omnisexual youth, asexual aromantic youth, unsure and questioning youth, and youth using another descriptor. In this chart, you can see the rates of sexual initiation across the different sexual orientation groups. And overall, 25% of the 15 to 18-year-olds were engaged in sexual intercourse, but there was quite a big difference between the subgroups. Even the mostly heterosexual were less likely than the heterosexual youth to report that they have engaged in sexual intercourse, but the gay, lesbian, bisexual, and mostly the pan and omnisexual children, as well as those children who didn't respond to this question on sexual orientation, were more likely to report intercourse. And probably it won't be surprising you at all, but this is the first evidence in Ireland that there is such a disparity. None of the asexual aromantic children were engaged in sexual intercourse, which also means that they are not part of the further analysis. When talking about the gender diversity, we can see that there is no significant association between the gender groups. And when we looked into transgender children specifically, we saw that there were around 4.0% transgender boys and 4.5% transgender girls. So unfortunately, we couldn't analyze them separately due to very low statistical power, but they are part of the gender diverse youth born as male and born as female. And even though there is no statistical difference, maybe due to the very low subsamples of the gender diverse youth, still, I would like to call your attention that the gender diverse youth born as female were more likely to report that they have been engaged in sexual intercourse. So even if there is no statistically significant difference, there is a clinically or practically significant salient finding that the gender diverse group who were born as female are more likely to engage in sexual intercourse. And from from this point, unfortunately, I cannot give you this granular detail of data, because now we are only speaking of those children who said yes to being sexually initiated. And we can see that there is a significant but small association between sexual orientation and early sexual initiation. And again, not very surprising, but sexual minority children were more likely than their non-sexual minority counterparts to be engaged in sexual initiation. And when we are looking into gender diversity, we are finding the same, around 2.5% who are non-gender minority reported they had early sex, and 8.3 belonging to the gender minority group said they have been engaged in early sex. When we are talking about condom use, and using no contraception at the last intercourse, we find no statistically significant difference between sexual minority and non-minority children. And what might be the reason for that? First, and I have to be very outright about this, we are speaking about a very low sample size, or only around 600 children who participate in the study in this age group responding to the questions on contraception use, because only the sexually active children got these questions. So even when we are talking about a nationally representative sample, there is simply not enough sexual minority and gender minority children to make meaningful statistical comparisons. And maybe had we had a bigger sample size, I could have shown you some statistically significant results, but there is a growing, an increasing trend that we are managing less and less schools to participate in the study and less children, and there was a big drop since COVID. So a lot of schools cited that they don't want to participate in the study due to COVID. And we have a national representative sample, but we had different difficulties in doing many of the statistical analysis because the sample is around 70% less than was in the last survey round. And the same goes for gender minority, gender diversity, and condom, pill, and contraceptive lack of contraceptive use at the last sexual intercourse. There is no statistically significant difference. And the optimistic explanation might be that all of the work which you had put into prevention and awareness campaigns are gone into fruition. So maybe there is a genuine, non-significant difference between their protection, but it can also be that, again, we are speaking about very low sample. But still, when we are looking into these granular comparisons, we can see that there are marked differences and statistically significant differences across the sexual orientation and gender diverse groups in terms of sexual initiation and early initiation. And pan and omnisexual, those children who are not responding those questions, and gender diverse youth born as female are at the most risk, while asexual and aromantic youth are at markedly less risk, which might not be a surprising fact. And we see from the mental health analysis that they have worse mental health than the straight counterpeers, but still in terms of sexual health, they are protected. Limitation we have already discussed is that there was just a handful of transgender children in the sample. If I'm not wrong, there were around 16 transgender boys and 21 transgender girls in the sample. So you see that's simply not enough to do even a simple chi-square, even not mentioning more refined statistical methods. And this might be the reason for not finding statistically significant differences. And HBSC uses a cross-sectional design, so we can't really make a causal inference from the data. We can simply acknowledge the fact that there is a difference in sexual orientation, gender identity, and they are associated with sexual risk. Still, I think these data clearly show that there is more need for inclusive education, and it seems in those countries where they are using inclusive curricula, not only sex education, but in other subjects as well, children are having better health outcomes across sexual orientations and gender identities overall. And it is especially true for sex education. And we know from other studies that many sex and gender minority children are expressing dissatisfaction with the sex education. They say it's not catering to their needs. Their special experiences are not covered in their life experiences, and their voices are not heard within it. But still, I'm a big time fan of doing straight and cisgender inclusive research, and it clearly shows that making such comparisons are very important, not only to show that there is a disparity, but also to make some more granular insights into that. And this is a slide for self-promotion. This is not HBSC, but you might have noticed that we are not talking about general population sexual health in Ireland, and Dr. Robbie Roller just called our attention to this lack of data. I'm very happy to report that in 2023, the HSE Sexual Health Program made a call for research award, which our team in Galway won. And we are conducting currently the Irish National Survey of Sexual Health. We are currently doing the feasibility study parts of it, and I know many in the room had already known about the initiative and input into it in different ways. I just wanted to highlight that we have scheduled the national data collection for 2027. And if this forum is interested in these results, I will be very happy to give you further updates on that. And we have also set up a project website. So if you're interested, please just scan the QR code or go to the link. And it's my pleasure that the next speaker is HSE Sexual Health Programs Research Manager, Dr. Nicola Connell, who will update you about the sexual health and well-being of younger adults. Thank you very much. Great.
Yes, so thanks so much, Jace. Thanks so much for stepping in last minute too. So yeah, look, next up we have a discussion on sexual behaviour among young LGBT people from BelongTo.
I'll try not to speak for too long because I know I'm the last person between you and your lunch. And I also want to kind of apologise for some of the images. This is the best that HSE can do in terms of the So I'm going to present some data today from a market research survey that we did, and this was commissioned by a HSE communications team, really in the context of the rising STIs, trying to understand what's going on with young people. We were specifically interested in the 18 to 30-year-olds, and we were interested in their sexual health behaviour, attitudes and their knowledge. So we had about 1,000, just over 1,000 people in this survey, and it was done online. Ipsos BNA were the people who commissioned the survey, or rather they conducted the survey, and it was a panel. So this was done online, everyone did it in their own home, and about 800 of them came from the panel. We wanted to get to 1,000, so my colleague Moira really helped there with sending emails out through students, student groups and advocacy groups. So all of this data was collected in January of this year. So we had about half the group were men and half the group were women. We had 3% of whom were non-binary, gender fluid or trans participants. 70%, 71% were heterosexuals, 12% were bi, and about 8% were gay or lesbian, and 6% were questioning, unsure, asexual, queer, gender fluid, homo flexible or pansexual. So I did that thing where I just divided them in half. I grouped all of the bisexual, gay or lesbians together along with those 6%. So we ended up with about 27%. I compared them to the heterosexual group. There weren't that many differences in terms of their demographics. So our LGBT group, so just to say as well that so the trans group are in that LGBTQ group because none were identified as heterosexual. There weren't really that many differences in terms of where they're living. So about 67% were living in urban areas, slightly more heterosexuals living in urban areas. The heterosexual group were slightly more likely to be Irish, and the LGBT group compared to the LGBTQ group. That's a mouthful, and it's going to annoy everyone, by the way. So the LGBTQ group were a little more likely to be of any other white background, but we didn't see any differences in the class distribution. So the mean age was, as you might expect, the LGBT group were a little bit more likely to be younger. They were 23 years compared to the heterosexuals who were on average 24 years of age. So we asked some questions about your general health, and we didn't really see many differences. The rates of smoking was probably higher than you might expect. Bear in mind that the Irish population prevalence rate for smoking is about 17%, but this includes kind of occasional smokers. So there were no statistical differences between the groups. Relatively high rates of vaping, but again, no differences here. No differences in alcohol use, but you can see differences in drug use. If you look at that yellow band up there, they're statistically more likely to have used drugs within the last year compared to the heterosexual group. We also asked people, well, how do you feel about your general health, like overall? And there was a really big difference here. I'm sorry.
So 10% of the LGBT group said that they felt their health was bad or very bad, compared to only 2% of heterosexuals. So if we dig down then, a little more then just on how they perceive their own health. So we presented them with a series of statements and we said, you know, what's important, very important, or really not important to you in terms of your own health. And for young people generally, so for as a group, the most important thing you can see there, everyone pretty much said that strong relationships with their family and friends was extremely important. But there were slight variations between our two groups. So LGBTQ groups were a little less likely to say that staying physically active was very important. They were everything you can see there with the asterisks. Less likely to say that reducing screen time was really important, slightly less likely to say that those physical health checkups were really important, and less concerned with reducing their alcohol consumption. So I've just highlighted that in red. But now we get into the sort of the sexual health questions. So we asked the same thing again. We presented them with a series of statements around their components of their sexual health, and we said, what's important to you? Consent was most important. So maintaining consent was most important for young people, and it didn't matter whether you're heterosexual or you were in the LGBTQ group. As you might expect, preventing pregnancy was slightly less important to the LGBTQ group. They're always in blue, but exploring their sexual identity and experience was statistically more important. So we get into the behaviour because we're in the HSE, so we're interested in their sexual health behaviour in particular. So maybe some similarities with András's data here. In general, the LGBT group were less likely to have ever had sexual intercourse. So that's the blue bar on the very right-hand side. So 24% had said that they had never had sexual intercourse, compared to only 8% in the heterosexual group. But the LGBT group were having more sexual partners. So on average, in the last 6 months, they'd had 1.9 sexual partners compared to the heterosexual group, 1.6. And we asked them, had you had condomless sex? And heterosexuals, again, were more likely to have had condomless sex than the LGBTQ group. So then we said, are you testing? When was your last test? And there were no differences really here, but maybe slightly surprisingly more the LGBT group had never tested compared to the heterosexuals. And we said, well, what was the reason that you took that STI test? And you can see on the far right-hand side, the LGBT group are much more likely to have tested just to know their own status or for their peace of mind. Whereas on the left, you can see the heterosexuals are testing. They're more likely to have tested because their sexual partner had had a positive test. And there was no difference in terms of their engagement with condomless sex in the reasons why they're testing. So we asked, well, when you think, we were kind of drilling down into some of their general attitudes around testing. So we said, well, thinking about testing for STIs, when do you think generally people need to consider being tested? And there were some very slight variations, and apologies for all the text on this screen, which you can see here. They're less likely to agree to the statement, well, if neither partner raises the issue, then it's really okay to assume that both are clear of STIs. And they're also more likely to agree that they should be testing before they have sex with a new partner, and more likely to agree that they should be testing if they have had sex without a condom. Again, more attitudes here, some slight variations, but not a huge amount. So we asked, well, do you agree or disagree with the following statements? And they're more likely to agree that a person can get an STI from oral sex. So we moved into the condom arena. In the following scenarios, when would you always use a condom? So LGBTQ kids are more likely to say that they would use a condom when having sex with a partner in an established relationship, and maybe not surprisingly, or surprisingly, if another form of contraception isn't being used, they're more likely to be using a condom. So we said, well, what, if any, are the reasons that you wouldn't use a condom? So this was interesting. So the heterosexuals are more likely to say that they're not going to use a condom just because it wasn't to hand. LGBTQ people are saying they're not using it because they don't think they can get pregnant naturally or easily. But the LGBTQ people are less likely to say that they're going to use a condom, or they're not using it because they just don't find it enjoyable or that it interferes with sex. So we asked a lot of questions around people's knowledge. So we said, well, what do you think is effective when it comes to trying to prevent pregnancy? And everyone agreed that that condoms are effective, but LGBTQ young people are more likely to say that they think the pill is effective than the heterosexual group,
You're also more likely to consider long-acting reversible contraception as effective, that short-acting contraception is effective, and that the emergency contraceptive pill is effective. But they're less likely to say that the pull-out method or the withdrawal method is effective. So quite a lot of knowledge, I think, on display here. We asked them, well, what do you think is effective against STIs? And we found, again, generally a lot more knowledge among the LGBTQ group. So they're more likely to say abstinence, which generally is just interesting. PEP, PrEP, DoxyPEP, and dental dams. So I think it's kind of more illuminating here as to what the heterosexuals don't know. And then we asked them, well, before you did the survey today, were you aware of any of these? Things? So again, more knowledge. The LGBT group were more aware of genital warts, HPV, chlamydia, and gonorrhea. And you can see there with HIV, that was the highest knowledge amongst both groups. There wasn't any difference. And of course, being the HSE, we wanted to know, are you aware of any of our own services? And generally more awareness. So they were statistically more likely to be aware of the free home STI testing service, more likely to be aware of the My Options service for unplanned pregnancy, and they were more likely to be aware of all group STI clinics. So if you get rid of all the heterosexuals out of the group, let's look at the LGBTQ group. We asked, well, who are the people, like what's going on with the people who've had condomless sex? So you don't see any differences. So when you compare the people who've had condomless sex and those who haven't, you don't see any differences when it comes to gender. And apologies for all of this text. There's no difference here with gender, age, sexual orientation, but there are, as you might expect. And maybe some of this is a bit counterintuitive, I'm not sure, around the health behaviour. So if you had a HPV vaccine, you're more likely to engage in condomless sex. If you'd used drugs now or in the past, you're more likely. But your attitudes seem to play a big part, which is, you don't need to be a genius to work this out, but if you don't think that condoms, or if you feel that condoms make sex less spontaneous or less pleasurable, you're less likely to use them. And if you know how to use condoms correctly, you're also more likely to have had condomless sex, which again, strange. And then when you look at who's testing versus who's never tested, we don't see any differences within the gender. We do see a slight difference with age. So the younger you are, the more likely you are to have never have tested. Gay and lesbian people are more likely to have tested. If you receive the HPV vaccine again, and these are very small numbers, so we can't draw much from any of this, you're less likely to have tested. And then just your attitudes here. So, if you're thinking that testing is expensive, that it's not easy to get a test, you're less likely to have engaged in it. And also there's this belief, I think, especially among young people, that these procedures are very painful. I think people imagine speculums and things really around it. So I think there's a lot here that we can use to kind of counter some of these attitudes among young people. And I don't know if the penny has dropped that STI testing is free in Ireland. And there are also these privacy concerns. So this view that people I'm living with might see, and again, not knowing that there is no branding. So I think, what can we do with this? I think what this says is, what can we do for heterosexual young men in particular? There are differences, I think, in the health perception, particularly around some of the more negative health perceptions. I think there's work there, but a lot of the attitudes and the knowledge is really high. They're testing to know their status, which is what the HSE want. But how can we help heterosexual young men? I think that was the conclusion. There is, I think from a comms perspective, that's a legitimate question. So I just want to thank everyone who took part in the study, and to the team who were involved in all the data collection. Thanks very much.
Thank you, Nicola. It's probably testament to everyone in this room, the fact that LGBTQ plus people are more plugged into these topics than very kind of harm. So, just before we break for lunch, it's movie time. I'm delighted to present Moved by Sarah Griffin, and just to give you a little bit of an update on what it is, where it's coming from. So, the movie recently premiered at the Queer Spectrum Film Festival. About 9 unique people from different countries are joined by one commonality. They're seeking international protection in Ireland because their identity as LGBTQ plus made living in their home countries unsafe. In this documentary, they're gathered in their local LGBTQ plus community centre in Dublin to discuss why they were forced to leave their home countries, what life has been like since leaving and arriving in this country where they're safe to be themselves. And most importantly, what their hopes and dreams are for the future.
Thanks, I forgot how to play this.
All going well so far.
Yes. I'd say they'll just push chairs back.
It'll last me about 10 minutes.
No. That's 1%, we don't need more.
Oh, you wow. Oh my God, you're always looking.
Two more chairs. I just don't need. Don't need extra.
I feel like that. I think I'm going to be a support. Oh, yeah, please.
Yeah, always.
Oh, jeez. Thank you. Of course, yeah.
No one came to see the post.
Morning. I was at night and a meeting got a call from
Very mild, you will. No problem.
And
Enjoy kind of know, people that
it's all the social cultural.
I was the one in Ballymore when we done one in St. Mary's, remember, in the lecture with Frisbee. At the end of the year, it was around November. Then it's like that. So it's
Oh, yeah.
It's totally fine, bro.
It's super.
It's not folded.
Oh, yeah, you guys.
And then my teacher knows the second would be in the lecture hall.
Sector, helps them.
He's gonna tell you that.
Me and doing it better. Like, these like the bean bowl. Get that, yeah. Some ways.
I'm proud of when you guys arrive at the moment.
He's just like so bad.
I can remember.
Wouldn't have that. You go to late. What's going on?
Well, and I can get from. We can show off.
You know, start to launch your
Operating, which I had to lose shit all the way. And I had dinner. He said, how do you feel? She goes, I feel amazing. Not at all. The one suit off Shane. Arrived on a fish. You know, it's the extra large. And I'm looking at the sizes. For 3 pieces. Not a big color, it's like a dark blue. Like you go like a plaid or something. And especially one of the gym was gone to a wedding. And I said, guess who? And he said, yeah, bring yours. When we were on looking at line conscious measure for sellotape. It's not sellotape, we're that was another night. She said to me, I don't know how you're getting like her 50. Kind of like a 3-piece suit that you got all together. Discount. Would not believe so, of course. Hutch said, you get the biggest of the biggest there. If there's a stage, exterior relays, so we can Jesse, I mean, I'm right in at 6 o'clock. No, I don't. I know. Well, when we go for the wedding for them, it says to me, she goes, put it on. I said, I've only ended up put it on. See what on. Do you know? I mean, it's yeah, well, she was. Put it on. She was through there, and you have the whole hoop canals hanging out.
So, something like a mirror image. Is there any way of changing that?
Like, I mean, I flexed it really hard. But I wouldn't be doing that anyway. I like where I to just Lens and everything, all perfect. We don't need to get anything from it. So I will never ever laugh as long as I live. Than me. You know, suit fist and tail. Because we were a first time buyer, I was. Discount on it. So when it was like 60 on it, I get this way. No. Like, all right, that's probably the same suit that I've worn.
You want to be you know, the really tight legs. All the other ladies free.
It's brilliant. She's a great social.
I don't think he noted. Doing Gaelic music.
So I haven't got
there.
Who are you talking where you're going to?
I was really hoping we would.
I'll see you on Monday.
Next time.
Are you publishing it?
No, you won't be able to meet him without actually doing something. That's what to do.
Yeah. Really not looking. You get the Not to miss the brave girls, no way I would have done it in Scotland.
Just permit transfer, it's all
Do about 10 times.
Presenting at the age
Standing on the road. You have to be I keep saying that the video of this stuff is giving us a kind of volume.
Yeah, it's because that would have been done way with
Oh, perfect. Doing it.
Nice.
Be all right.
Maybe alright.
Too, it's great. Speakers have been really good. It's always the way, isn't it?
I can.
The clicker. Rather.
Oh, she says the minute she gets back, she's going to try and get in as quick as she can. Chill, gets home, big shower, gets ready, jump on the bus. But the bus takes a long time.
There's so much wrong with
Later, he's only up there. He's literally rising. So he's right past process. Go down. Stay wide in front. It's all there. Well, that's true, yeah. No, €2. €2 it is. I'm not claiming anyone. You're right. You don't want to even know the sexual health policy. It was great. Yeah, claim that it's 2 kilometers. It's not even more than time, even typed it on the system. So you should be claiming it and all.
The reason why
You recognize the force lines. Only a little bit. We don't give a little bit of meat, it's a big piece.
well, we know, don't we? We know. Loaded.
Live up here and
You know what I mean?
She's thinking of it. She's weighing up her options. I think that's killing her. I said to her, you're looking at you're wasting over. I think it's kind of the work within the system. I just have to work for her. She said, I'm never here to maintain a relationship.
Very nice. It's just when we see it on our video. Show it.
You know what kind of reminds me of Maria? I remember when we the debates when the woman was there and he says, just a plan. Should be like, debates down there, like, no. Plus, what was there? She was trying to highlight. Remember, she was. In top of you when the old discussion came about the debate, she said, and she was, so well, you learned that way. Yeah, what's called she said to me, you know, I used to do the midwifery stuff for a lot. I have to be very happy. Yes, I just really so close. It's near. You're wasting 28 hours. She's wasting.
I would never forget as long as I'm
Not even. Less than that. And they said, 2 days. A lot easier. Thank you. Different stage,
Thanks.
you can absolutely understand. No, she said, I said, last night. Yeah, I said, spanking boys. Just really we have no wishes, or you know, we for
Here. What about it's not very small. Right.
no.
Not right now.
The last person she asked.
No, it's tomorrow at 11.
I think there's a big argument to have it because of the way.
So I've left it there.
It's
not a lot of green glasses.
Yeah. Oh, it has to be straight across.
Cover your mouth.
You're very popular man out there.
Yeah, go to there. Let me get at least one of you guys and then we can.
The argument.
No.
The light over there.
Take a picture. Take a picture. Great service.
Let's say next year, sexual health policy year. Let's say
Thing behind us. Great.
So that's what
You're trying to what are you doing? Sure, it's great. We all agree on that.
Yes, many pictures. Beyond that being person of nothing else.
By the
We can talk a little bit.
what do you have to
Aaron, I've driven them around a lot.
Oh, that sounds good. Okay, so we won't use that one. You know, have to use that one.
That has become very inspiring.
Yeah, one nice one.
Yeah,
For the angles that I look like. Lovely, lovely.
So, question, and that's it. Pastor says, I don't know what's wrong. So I give it the other. So if it's on, oh, so I said.
Yeah, I know.
I thought I thought we clarified when I
They here like 2 years of one.
Looking for you, and then I get home.
Start people saying second the link and it would it's clear brain. So we do. Now, yeah, that became a so I think Sorry,
didn't say.
I mean, that's just.
Oh, no, highlight. Sprinkles.
That was enough of a minute.
Yeah.
Well, I've got I
know we got. Oh. I am right now.
my work, alcohol.
I was ever at a stage of someone said, you're okay.
I like it.
Yeah. You ever seen a clip from one of the last second? Always see, oh, it's horrendous. Like, I mean, usually, depending on how. Here's the album, the moment. That was a one-off shot, and I went.
I think I would feel like I would never.
Hardly was cutting on.
It was very warm and
Around there.
Yeah.
Find out in. When I see, I never. I think.
I'm just wondering where we. Somebody to.
Where will we find the very, very good. I'm feeling yes.
Oh, what we left. I'm talking about next. Like maybe but so we should be he'll have his qualification there.
Oh, and also in our age, all psychotic. I'm not worried about the age, the madness behind the eyes and. It's not like the army, what he might say, you consider staying on. Boy, for all that would be. Everything, anything she can run down. He has a count. She's registered. Talk to me about something Oh, okay. Here's something on here, and you're right.
Just getting everything.
Perhaps having really bad needs it's where you are.
Just a Wednesday.
No. I'm just ready. There are bridges you want to try and rebuild. I don't rebuild the bridge. Until you're in
Like was originally
I know, yeah.
Well, listen.
I'm here.
Oh, yeah, no, I was.
You know, I'd love to, actually, do you know? So you do.
I was saying this. It's cheap, so put this is saying when you're not like.
Lunchtime seminar.
Yeah. You will have that. So if you're falling around.
This is me in an adjunct.
She says, you know. All it is, it's like college. If there is no concrete, don't.
I'm not sure that I want them.
Something much a library is though. Stop reading.
It's still out there.
Yeah.
Did you see any
No, yeah, no.
First strike to me.
I don't.
Yeah.
We're like,
It doesn't show. No, Dublin. When she's it takes over.
Nice to meet you. I think we are friendly in Lincoln. Happy to meet you. What do you run? You were. Welcome to
That was a two.
It's here. I love the project. Really good.
Really?
Rang me.
Yeah, I got it.
Oh, very based on strength.
This is where the gap.
Well, it is, yeah.
You're right.
I'm gonna do be with us in a
Yeah, say that now. No, I'd say it's about 10 minutes from here. We are now. 10 minutes to your left. Cross on the. Yeah, don't worry.
Yeah, you like back about in my mind, it's not
No, it's like sorry.
Hello, hello. Testing, testing.
Welcome back, everyone. Just before we get going, I know it's been alluded to a little bit, and I think kind of networking. We had a very special birthday recently. One of GHN's board members, an Olympic swimmer, Mick, was celebrating his 75th birthday, and just as a gesture, we got Mick a cake, and I needed it.
Birthday was last week. Happy birthday, dear you. Happy birthday, dear you.
Oh dear, what did you do?
Not let it blow.
I just wouldn't fit on it.
And thanks
for everything.
So just before we get back into things, I'm sure you've probably seen some of the brilliant posters that are on the back wall, and just to shout out to the artists and to those who support our movie piece. I think the art definitely brings today to life. So kudos and thanks to everyone for all the support with the artwork. So jumping straight back into things, of course after lunch we have Ben Lindsay. Ben is going to talk through sexual health science.
Oh yeah, I can't do this on my own, unfortunately. Thanks very much. Happy Friday, everyone. Hi everyone, my name is Ben and my fabulous work colleague here is Kirsten. We're both work wife, sorry. We're both health promotion and improvement officers for the HSE. So we cover Dublin, North County, City and West. Our slides that we have is just to highlight really how the sexual health signposting training for professionals started and where it is today. Hope you know this clicker will work. Right, so we were approached when I literally started in the HSE as a health promotion officer. We were approached by social inclusion within CH09, their head office in Ballymun, and they identified a needs that they had, especially when it came to staff that were supporting IPA. They found that there was a bit of a missing gap around the area of sexual health, that there wasn't an awful lot of knowledge for staff. They didn't really know anything about resources, signposting services that were available. And because of that as well, when the area of, or the discussion of sexual health came up, because they didn't have that knowledge or no knowledge at all, the confidence was pretty low, so they just kind of avoided it. So they approached ourselves, which was the Health and Wellbeing Division. They kind of linked in with us and asked us what resources were available. But what we done for us was we had a meeting where as many organisations that we could have that were supporting international protection applicants and migrants. That was a 3-hour meeting. I think I wrote 8 pages. But what it really done was it's kind of re-emphasised the needs that social inclusion highlighted. So what we decided to do was we linked in with our department, which is the Health and Wellbeing Division, the Sexual Health Programme and Aquida. I want to give a massive shout out to Kiva, who unfortunately is not here, who works for the Sexual Health Programme. And I want to give a big shout out to Hope and Patricia, who work for Aquida. We would absolutely have never developed a one-day workshop if all these parties weren't involved. It definitely was a big team effort. It was. So, while we were kind of developing the overall workshop, we kind of looked at reports. There's plenty out there, but you've seen with the documentary that I'm seeing there, the experience that LGBTQI plus international protection applicants go through and their overall experiences. So we looked at 2 reports that really stood out to us. One was through the Irish Refugee Council and the LGBT Ireland, highlighted the lived experience of LGBTQI protection applicants in Ireland. So what's really stood out to us while we were putting and refining and manualising the actual workshop itself, that the reports highlighted particular challenges for LGBT plus applicants. For example, as applicants' lack of understanding of the international protection system, which I say is a maze, and the increased fear and stress around disclosing one's sexual orientation and gender identity. And what really stood out to us is because people probably either never disclosed it at all, or maybe they were still dealing with what was going on, whether it was their own orientation and their identity. Right, so like with any workshop, we kind of had to have a structure. So we wanted to make sure we needed to have what our target audience was, what our aim was, and what our learning outcomes were. So our target audience was professionals that were working with international protection applicants. My apologies, I have to keep saying IPAs. So our aim of the training was to support IPA service users access to sexual health through the building of capacity of relevant professionals to signpost appropriately. So with the workshops that we delivered, we had 3 learning outcomes. And basically when people completed the 1-day training, it was to have some basic knowledge of some of the sexual issues and services and know how to access additional information, have enhanced their signposting skills, responding appropriately to service users' sexual health information needs. And I think really the most important was to feel more comfortable and confident in discussing issues of sexual health as appropriate to their role. We just really wanted to get people in a good place that if they wanted to promote sexual health within their organisation, or if the actual subject ever arose, they were confident enough to say, I can support this person within this time I can. Right, so we decided to roll out our first pilot, which was in the Ballymun Civic Centre. It was 6 people that turned up for it. Our first pilot, we crammed so much into it. I'd say the last hour I must have spoken about 100 miles per hour, everything out. Have you got enough? Have you got enough? We delivered as we did, and then based on the feedback, we kind of refined the workshops. We delivered another workshop in St. Mary's Hospital around November time in 2023. We had about 15 participants in that. That was in the lecture hall, and then based on that, we also refined them and what you call it, made sure that we were actually delivering what we said we were going to deliver. So in November 2024, the pilot was extended to 3 other CHOs, and 7 trainings were delivered across 4 CHOs in total, which is really, really good. Now, the pictures that we have here, so we delivered our last 2 workshops in Balseskin Reception Centre. The staff there are absolutely amazing. So on the top left-hand side, we had our first group from 2024. We had a huge amount. We kind of had about 16 people that said they're going to turn up, and then next minute it turned into 26 people. It's just people were turning up going, I was told to come here and just, there's a workshop here. But it was really, really, really good. And because of the success of it, Balseskin then for 2025, they provided us with the room, the resources, the catering, and we delivered our next one, which was this year in April. And Balseskin have absolutely seen the actual benefit of the workshop, and we're hoping that that relationship will be developed, and please God, we can continuously just deliver this each year and refine it and everything else. So I'm going to hand you over to Kirsten.
Your sidekick, as always. No one ever remembers my name. Badly. So supporting resources, one of the things that we did find was that it was so much information to give everybody. There were leaflets here, there were websites, and one of our colleagues and one of the CHO1 put together this fantastic e-booklet, and it covers everything. And it has a couple of pages on IPAS LGBTQ community as well. So it's just a really useful support, and we're happy to share it afterwards as well, because it's for everyone that works with anyone in relation to sexual health. The evaluation of the training, a pre and post evaluation was developed to measure participants' perceived levels of knowledge and confidence in responding to sexual health queries, and this is measured by the Likert scale 0 to 5. The results, participants' knowledge of Irish sexual health services increased from an average of 2.6 to 4.6 between the pre and post evaluations. Their ability to signpost to required sexual health services increased from 3.4 to 4.7 between the pre and post evaluations. So as you can see, it was a well-worthy training and hopefully something that we can move forward with. So next steps, rolling out further, evaluate and refine the one-day training programme for professionals, working with IPAS as highlighted under the actions of the National Strategy, Sexual Health Strategy, and then exploring for opportunities for adapting this one-day programme to focus on other minority groups such as Traveller, Roma or the homeless communities. Does anyone have any questions in relation to what we did? Thank you, by the way.
For us, we just wanted to keep the presentations short and sweet, because I knew it'd be 2 o'clock on a Friday. People's brains were just taking in an absolute amount of information, but sometimes less is more. But if you have any questions, please feel free to throw them out. If you don't, we'll run back to the back of the seats.
Sorry, where do you access the booklet? Sorry, just for the booklet you were saying, where do you say access that?
There's a Publio link that we have. Yeah, we can definitely sort that out, and we'll link in and stuff like that. But it's a really good resource. Really good resource. Thanks everyone. Thank you very much for that.
Thank you so much, Ben. I'm Kirsten. Brian's going to give a quick introduction to research around LGBT artificial perspectives.
Thank you. So I'm just going to talk a little bit about my service in the Sexual Health Centre in Cork. So I'm the LGBT Y+ sexual health counsellor. Before we begin, I'm going to look at the picture of our building. So we moved building about 1.5 years ago. Before we were in a dark alleyway and just a little bit dodgy. Now we're on the main streets of Cork. So it's a nice progression about the sexual health in Ireland. Really nice things about that. Cool. So who am I? So as I said, I'm the sexual health LGBTI sexual health counsellor in Cork. I suppose what I'm going to talk about is kind of some reflections and ideas and commentary I've been getting from my service around sexual shame and just the different experiences people may have getting tested and screened. What's probably the most important part of this slide is the, let's see, Cork in brackets. Yeah, the Cork. I can see most of it here. Our national Cork. So what is sexual shame? So as I'm sure most people within the LGBTI queer community will have a good awareness of what shame is, what shame feels like. But for lots of people, it's this really heavy, sticky feeling that I am a bad person, I'm inherently wrong, or I've done something really bad. I suppose with sexual shame, as I go through the kind of different reasons why we experience this, can be very, very difficult and can really be a huge barrier to accessing or to, receiving services or own services. So it's about internalized internal factors. So one of the major things that lots of people experience is internalized phobia, be that homophobia, biphobia, transphobia, queerphobia. And this can be something very unconscious that most people not actually be aware of themselves. Inherent beliefs that we receive from family, religion, culture. Discomfort with pleasure, which is a very common thing I experience. Lots of people feel because of such sexual shame, it's not okay to feel pleasure, to enjoy pleasure, yet there's obviously a natural pull because sex is so important. Generational trauma. So basically in Ireland, as we all know, we have shady kind of experience in the past around sex. Sex has often been forbidden. You can talk about within baby homes and laundries, and of course fear of clinical judgment or fear of judgment in general. So external factors. So different STI stigma. Even though we all do really hard work, there is still a huge stigma within the community. Cultural taboos about queer lives or cultural taboos about sex.
There are things like, that women can't contract for HIV, and different things that like every queer person is really promiscuous, we have to be promiscuous. Also kind of different myths about sex and how we contract STIs. So the impact, so a real disconnect from the body. So when you're experiencing sexual shame, you become really kind of disconnected from your body. You don't receive any pleasure or enjoyment in life. You've really started to disassociate. You struggle with intimacy in relationships. Can be conflicted with identity and belonging, and this often results in isolation, silence, avoidance of care, compulsive sexual behavior, and sometimes chemsex. So what does it, how does it impact in screening? So when somebody goes to a clinic, somebody maybe have already experienced a lot of trauma in their lives. They may also kind of start to minimize themselves, or the kind of their sense of their queerness starts to become smaller. Kind of trying to pass, how can I become like, straight enough? How can I answer the correct questions so I can access PrEP or DoxyPEP? Maybe even though people may get like, a non-reactive result, there's still maybe a feeling of shame and dirt, which again can make people reluctant to approach services. Worrying about being seen in the clinic. There's a number of smaller clinics outside of Dublin that you would see absolutely everyone in the waiting room. But sometimes it's going to be lovely, but also it's embarrassing, shaming for some people. I suppose one thing that kind of really is a barrier for lots of people is sometimes the questioning that may go on. How many sexual partners have you had in the last 6 months? How many sexual partners have you had this year? How many sexual partners have you had in your lifetime? Which I'm sure is really important, but also it's like, outside of one or none, it's incredibly, the answers can be incredibly shaming. And like, for lots of queer LGBT people, we are traumatized. We're really sensitive to microaggression. So like, that certain tone or that kind of wince or that kind of like, it's a very subtle reaction, can make it really small, you can minimize, and eventually we just start lying. So most people in my clinic usually tend to just lie to the answers and hopefully just get the right number to get access to PrEP. So kind of general anxiety with feeling disclosure and perhaps lack of support. So my insights, so quote, having a really really important to have a close community and community resources. I suppose a part of that as well, like, being a therapist, being a queer man myself, like, it's quite difficult, to be in a queer community and also after services, it's important to have really important boundaries. Having like, counselling room that's free of shame. Name it, tame it. There's something going on, it's a problem. Someone's feeling shame. Someone's having a problem with a service. Name it, report it, make a complaint. Encouraging self-compassion. I suppose queer joy is something that's really important. That we don't. Sometimes we kind of fall into pathology. What's wrong? This STI, that STI. This is a problem. This number's going up, and that number's going up. We don't talk about the importance of being a queer individual, what that's like, what does that mean, and how that can really improve policy. So my key takeaways, shame can be subtle, silent, but pervasive within the queer community. There is both personal and systemic factors that need to be addressed in policy. Queer affirming spaces are really, really important. Ideally, free counselling services available in collaboration with every sexual health clinic, and embracing queer joy and celebration of LGBTQIA+ people. Thank you.
Outside of the counselling room, what are the best things that we can do as a community to try and help overcome shame?
I think it's a collaboration of different things, so supports, having different groups. But I think as well, like, you know, sometimes within the community, there can be a lot of shaming as well. We kind of talk to each other a lot. So that needs to be addressed. Sure, how we address that? But like having different groups and different supports, but having a kind of clear signposting network is most important. Thanks, Rob. Cool. Thank you very much.
Graham's from Cork, if you haven't realised it. So next up is James O'Hagan. James is presenting the topic on death and dying. Tuaca Guide, Ember.
Thank you. Have I listened to any presentation today or spent the entire day worrying whether this would work? See. So my name is James O'Hagan and I'm here to talk to you about a project that I've been working on for the last couple of years between ourselves and LGBT Ireland, the Irish Hospice Foundation and the All Ireland Institute of Hospice and Palliative Care. You know, among the few things that are certain in life and the experiences that we will all share, death is absolutely one of them, both our own and very, very likely how we will react to respond to the passing of friends. And so we want to explore how our community, I suppose, was served by those services that exist currently, and what gaps may exist. And so the first thing that we started, or the starting point for this conversation, was understanding what it meant within the queer community when we spoke about end of life. I don't know, I've recently done a rewatch of the entirety of Downton Abbey to prepare myself for the third film, and so I was struck by the ending scene of the second film, where, spoiler alert, the Dowager Countess dies, surrounded by her family and the warm embrace of all those people around her. And clearly that is the vision of the end of life that we would all hope that we're able to share. But the reality is that when it comes to our community, what we're constantly hearing and what we're having reinforced to us is stories of violence at the end of life, or of suicide, or the shadow of the HIV and AIDS epidemic which we live in, and the unrecognized grief that has gone alongside that. So the sort of the relationships and families and communities that have been built but swept aside when individuals have come to end of life. And so we wanted to discuss, well, what about reclaiming dying grief for within the queer community, and what if it could be similarly a space of care and community and dignity for the LGBTQIA+ community. And we did this, I suppose we've approached this over the last few years through a number of different approaches. The first was a series of, we've had, I suppose, around 10, maybe 12 at this point, death cafes. Oh, we'll go back to this one. Death cafes, where we brought people from the community together to speak about this issue and hear directly what their issues were. The creation of a bereavement support group, though whether there's a sort of enough of a want for this space at the moment is something we're struggling to determine at the moment. And the creation of the Ember Guide, which is a resource for the community, for health and social care professionals, for individuals who are caring for someone, to help them understand some of those nuanced ways in which our experience and our identity makes us maybe sort of makes things slightly different for us. But to get to the next slide, why does this matter for us? No, this is all data from different pieces of research which you can, you know, take a photograph or go and listen. But basically the story it tells is that as we age, and I know that sort of death doesn't only occur among older people, but it is sort of the population with whom it's sort of probably most front of mind. But for our community, we are more likely, as a result of the circumstances in which we live, to rely on external services to provide support, and in a way where our personal circumstances will become more exposed to many people. We also are much less likely to trust those services actually are going to be able to meet our needs, protect us, and actually treat us with dignity and respect. One piece of sort of good news that I suppose that comes out of not just research into this, but also through conversations I've had, is that our community is proud to be, and particularly older members of our community are proud now to be the community that are defining what it means to have our relationships exist out loud, our families exist out loud, and what it means to have our legacies and our passing and our death be sort of, you know, open and have that conversation. Well, what does it mean and what does it look like? Which is something I suppose that we can hold on to as we move on and decide, well, what do we want end of life to look like for members of the queer community? So this first came around in 2022 when myself and Paula from the Institute of Hospice and Palliative Care and Valerie from the Hospice Foundation decided to run a death cafe as part of the Palliative Care Week events. And this was specifically, I suppose, to give a space to figure out what are the issues that are coming up for members of our community. And from there, I suppose it's grown into something much bigger. With this and the 10, I suppose, cafes that we've run since, I suppose we had anticipated that it would be primarily men, that it would be primarily older people, that the individuals who came along would be very anxious and afraid, and that we would need a lot of like games and gadgets available to fill time when people sort of would be stunned to silence. But actually what we found across every one of these events that we've run is that there has been a huge mix of gender diversity, of age diversity. People are eager and excited to be there and have wanted a space like this to actually sort of speak about some of these issues that have been on their mind, and the time absolutely flies. We are ordinarily having to like bring people back into the room. Right now we've got 10 minutes left. You need to sort of say anything you want that's on your mind, and then we have to close it up. And people really have been enthusiastic, which is why we've ended up sort of running so many of them and hope to continue running them into the future. And the four main takeaways that have come across all of the across sort of the conversations is, first and foremost, that there has been a repeated ask that there would be queer specific bereavement support, that the supports that currently exist to support members, to support people who are experiencing grief or bereavement don't maybe understand or meet the needs of members of our community, or don't feel particularly open to our community. There's also a real, and this isn't something that I've worked on, but something that I think an interesting sort of piece that keeps coming up is a want for really authentic intergenerational spaces, places where our whole community can be together and can feel that. And this isn't, you know, perhaps you might assume that this is older members of our community wanting to feel accepted within spaces that younger people occupy, but actually it's that the younger and older people together want to feel like we're part of one community. There's a one for kind of creativity and defining what it is to celebrate a queer legacy and to remember a person with their identity, and then also a more sort of tangible one which we were able to work on, that which was the creation of the LGBTQI+ reference group and the development of this resource. So in 2023, we got funding through DCA DIY to run this, to create this focus, this resource. We were lucky enough to have some really sort of real enthusiasm from sort of people, prominent people within our community who wanted to be involved and wanted to sort of have their say and help us put this together. So there was ourselves with the Irish Hospice Foundation and the Institute of Hospice and Palliative Care. We also had people working from palliative and hospice care, academics and researchers, people from working within the funeral sectors, people from media and design backgrounds, and LGBTQI+ people with that lived experience, both with the trans community, migrant community, and intergenerational voices within the space, to kind of come together and build something for an Irish perspective. Kind of what do we need people to know when they pick this up? And so the objectives were to, I suppose, provide perspectives. Yes, very appropriately. This was these photos, I should say, were taken from the launch of Ember that took place last October. And we had a couple of coffins, and everyone got a chance to get in one before the end. It was a wonderful event. If anyone got to go there, we hired a professional funeral singer to come along and do it, and it was sandwiches with the crust cut off. But the objectives were to get a genuine perspective on the community of what our needs were, increase the visibility of the issues of LGBTQI+ people at the end of life, and to make sure that the quality of care was improving as we were kind of leaving it as sort of something that would ideally improve the quality of care that LGBTQI+ people would receive in those spaces. So we worked together. We realized that around the world we weren't the first people to have this idea. There was many people who kind of had thought about this before, and guides have been created in various places we took them and said, right, well, these are all going to provide us lots of great information, but they're not going to be Irish and they're not going to work in the specific I suppose settings that our community or that our community and our population need them to. So we sort of started working from those and drew together from all the perspectives in the room to build the Ember Guide. And I'm not going to go overly through it because there'll be a QR code and you can have a look at it in a minute if you want. But I suppose it has three uses. The first is for members of the community who may be coming towards end of life and wants to sort of make sure that they have thought ahead and planned ahead. It's about forward planning, which really is, I suppose, the most useful thing you can do to make sure that when you get to that point of crisis or that point sort of down the line where I suppose you're in that emergency, these decisions and these conversations have already been had. You've made them and you don't need to worry about them. We also wanted to make sure that health and social care professionals that were supporting members of our community had somewhere that they could go to find this information. And we wanted to make sure that if you were experiencing a bereavement or if you were supporting someone through that, that you had somewhere that you could go as well. The guide sort of helps people to plan from where they are now, really leaning into that think ahead. And it sort of is I suppose designed to be used in tandem with the Irish Hospice Foundation Think Ahead Planning Pack, which is a useful resource that you can I suppose use to really get your thoughts about kind of what you want your end of life to look like down, and it's used then when you were no longer perhaps able to advocate for yourself. Useful kind of what ifs and useful resources, thinking ahead, thinking about honouring life and after death, kind of what may be involved. And if you want to have a look, you can scan the QR code and have a look at that now, and I will take any questions if there are any. Oh, yeah.
That was absolutely fantastic and not as depressing as the title would. But what I'm surprised about is like when you started this out, did you foresee it being something that people were so keen to talk about that would span 12 sessions and then some? Or was it seen as a once-off?
No, we had several crisis meetings in the days and weeks leading up to the first one, where we assumed that, and every other one since that no one would show up, no one wanted it, that it was a weird thing to be going. But actually, I think at every instance we've been incredibly surprised by the enthusiasm and the want for these kind of spaces. We have been trialing a bereavement support group over the last number of months, and I'd say uptake in that hasn't been as, I suppose it hasn't been as reflective as maybe it would have been suggested by the one for the death cafes. But I suppose it's, you know, it does show that people want a space to talk about this issue and maybe have anxieties about it.
Amazing. Thanks, James.
Thank you. Oh, one more question.
You do wakes and after parties?
Yes. Making information available on the LGBT Ireland website. Yeah.
I wasn't going to say anything actually, but the funny thing is, I had found the Ember, the catalog by accident, because I was searching to see which solicitor who would I go to do my after I died thing, you know, as you get to my age. So it's either sexual health on one side and death on the other. But in both cases, and I think this is why I'm saying it, one of the frustration things I have, and is if you want to be independent and do it, even online, it's such a minefield.
Yeah.
And there's nothing free. So even if you want to go to solicitor, it's the minimum is €200 across the board. So I do think there's a place for Outhouse or for the Sexual Health Centre Cork that part of the services probably is some sort of support within the community. I'm lucky I have a pension, but imagine if people don't have resources or wherewithal. How to get stuff for someone to sit down and do that. Like if you go online to do your will or to do your thing, to take it to the next stage, even it's costing money, or it's a minefield. So
yeah, I was down recently having a conversation about this in Gay Project in Cork, and they I think in Cork have run a couple of sessions actually with their older persons group kind of on the creation of wills, where they bring people in and they do it for free and bring you through it step by step. But I think it is something that could be taken up by the centres that exist around the country to try and offer that, so people are able to do it in confidence that they're doing it right and they're getting it right, and also that they aren't paying for something that they don't need to be.
And within that system, then
you could have your witnesses within that support centre.
Exactly.
You know,
exactly. Yeah.
it's just a suggestion anyway.
Thank you very much.
Thanks, James. So next up we have Mira Fay, who's going to give a quick overview on community-driven healthcare access and mental health promotion for inclusive, equitable, and resilient European societies.
Yeah, annoying PDF presentation as well. Sorry about that. I can attempt to flip it, but I think it's probably better. All right. Yeah, so the long title is very long. So the quick one is EquiCares. And we at LGBT Ireland are running part of that project since this year. It's a 4-year project that I'll say a bit more about. I'll briefly go over the LGBT Ireland core activities, although I'm relatively sure most of you have some idea about that, but then talk a bit more about the project and what that means in Ireland. So what we do at LGBT Ireland started as the helpline, then sort of evolving into offering lots more support services, peer groups. I mean, James already mentioned quite a bit there in specific ways, but also we have a telefriending service for all the LGBTQI+ people, online chat and signposting information services. Those kind of services and the insights we gain from that then inform the training we do. So we have a champions program to create change in the healthcare system for LGBT inclusion, and also tailored LGBTQI+ general awareness raising trainings to all sort of sectors of society, and also engage in lots of different advocacy and research. So for instance, political lobbying for hate crime legislation and the ban of conversion practices, but also publishing reports. I think there was mentioning of another report earlier. So I think that's kind of the overall activities. But then what is EquiCares? It's kind of a mouthful, so I'm not going to repeat that again. But what EquiCares aims to do is to develop and pilot sustainable and locally replicable solutions to mental health care barriers. So that means looking at what are mental health care barriers, and then also how can we overcome them, and can this then be rolled out more broadly in different locations. The program overall focuses on different vulnerable population groups that have additional access barriers and maybe limited education about available local support. So that could be LGBTQI+ people, as it's in our case, but it could also be migrants, refugees, people with disability. And the goal is then to identify digital support options that help address rising mental health issues across Europe. We've heard a little bit about this in other presentations, how the LGBTQI+ community is kind of across the board disproportionately affected by mental health issues. So that's quite an important thing for our community as well. Thank you. Bigger project. So the bigger EquiCares project involves a lot of different partners across Europe. There's 18 partners in 9 countries. It's a 4-year project funded by Horizon Europe. And as you see, there are academic and research experts from different universities, health experts and healthcare service providers, civil society organizations such as LGBT Ireland. There's also Jigsaw, another mental health organization in Ireland. And then there's network organizations and innovative organizations. And as a consortium, we all come together to sort of work on this project. It's quite chaotic at times, because there's a lot of different people feeding in, a lot of different partners feeding in, providing different tools. So while it started at the beginning of this year, we're still sort of in the process of getting properly started with ethics approvals across those 9 countries. It's a long process, and I think it will be quite rewarding as well. So what is EquiCares in terms of content? We start this year, once the ethics approval have come in, with research elements. What other partners have already done is they looked at a theoretical framework to access to healthcare. So that's the Levesque framework. I'm not sure, maybe some of you might be familiar with that. That's looking at different factors influencing service providers, but also service users. And they have adapted this to a mental health care setting. Other partners are looking at what are innovative mental health solutions and are in the process of developing an atlas. And Europe-wide Delphi expert survey is already underway in the pilot countries. So as in Ireland, there will be interviews, there will be surveys and a diary. When it comes to the implementation, then the goal is to co-create smart health labs, and those will be based on co-creative workshops with community members, local experts, and other stakeholders, and then be rolled out over sort of 2-year framework. And there's going to be also evaluation of this and dissemination, kind of different sessions throughout, and hopefully the solutions will prove effective, and then we'll try to find some way of kind of keeping them going afterwards. Yes, I think that makes it kind of an interesting project in a way. I mean, different in the sense that it's identifying mental health barriers, but then also trying to identify what can actually work. So that's, yeah, a nice way of that. Thank you. In Ireland, so I'm the research lead for LGBT Ireland of the project, responsible for the implementation, have gained adjunct status at UCD through that, and have experience working on barriers and through kind of inclusive access and good practices for LGBTQI+ people. Then there's Adam, also from LGBT Ireland, who's the head of services and engagement programs, and works on lots of different services, looking also at mental health support and all other sort of support for the LGBTQI+ community. And then we work with Paul Dalton from UCD, who is supporting us, for instance, with the ethics review at the moment, and will then also support further on. He, and maybe some of you might know him. He is professor at UCD and has, a long time working on LGBTQI+ mental health. So what do we do at LGBT Ireland in EquiCares? We are the only pilot partner among partners you've seen earlier who are focused on LGBTQI+ people. So this gives us kind of a unique role and opportunity. We couldn't focus on all of Ireland, so we have selected the former CH06 region, so Dublin South, Southeast, Wicklow and Dún Laoghaire, which has about 400,000 people, and also experiences specific challenges such as oversubscribed mental health services. I mean, I think that's not necessarily a local challenge, but restricted public transport in rural locations, housing crisis, and also, there is the National Gender Service. So I think that's a unique part to CH06 that doesn't exist elsewhere, as we heard today as well. And of course, there's also some resources, services in place, but it's also close to Dublin. So that makes it sort of a good choice for us. And then also when it comes to LGBTQI+ mental health, in specifically CH06 was a study that was conducted in 21, indicated that the biggest sort of disparity between LGBTQI+ service users and their non-LGBTQI+ counterparts when it comes to mental health issues. So that's also another reason why we selected this as the pilot site area. Thank you. So what do we do in EquiCares? We will carry out the research in countries. So as I mentioned before, there's other research activities done by other partners, but we'll do the interviews in country. We'll do 2 different surveys on mental health access barriers, and we'll also do a diary where people will describe sort of their experiences more sort of as a narrative. From next year onward, we'll start setting up the Smart Health Lab through a co-creative process. This will then also include us doing continuous monitoring evaluation And hopefully, if what we are developing together with the local community is successful, then we'll try to secure funding for that also more long term. The goal why we're doing this and why sort of we got involved in this bigger project is to create more accessible and appropriate information for service users from our community, but also to upskill mental health professionals about the LGBTQI+ community, and for instance, to advocate for LGBTQ voices in strategies such as the digital strategy and others, which I think is another important point for us. Given a bit of starting off, I also wanted to include some participation opportunities, if this has inspired any of you to sort of think this is a really good idea, I would like to get involved. These are just some examples what could be happening, how you could get involved through the next sort of 3.5 years. So there's a lot of time, even if you think not today, but maybe next year. Also great. Yeah, that's kind of that. I have my email address on the next slide. If you have any comments, if you want to reach out, please feel free. Yeah, that's Equicares.
Thank you, Mira. So moving on to our next part of the day, which is a mini session on trans health groups. I'm delighted to welcome first Jessica Black, who's going to give a quick overview.
Hello, everyone. As I right button. Next slide, please. My name is Des Black. I use she/it pronouns, and I'm on the committee of Trans Healthcare Action. I work mostly on policy and research, so talking to politicians and sending lots of freedom of information requests. Next slide, please. And then Trans Healthcare Action, we are a grassroots group. We've got 60-ish people, and we're looking through an informed consent trans healthcare system, following international best practices, and it's human rights based and in the community. Next slide. So what's our current situation today? Next slide, please. These were 3 articles published by Carol, I should say, in the journal earlier in this year about the status of trans healthcare in Ireland. These include words like traumatized, denials of care, people being asked about their sexual life, denials, and people being forced to DIY because there's no other option. So things are not going well. Next slide, please. So the current system, we've previously been ranked as the worst in the EU. As well as that, we have a de facto decentralized gender clinic model, and there are no national guidelines at all about trans healthcare. Next slide, please. The systems we have, obviously, massively long waiting list. It's going to keep on growing. Youth services are non-existent. We can just send them on to a service over in the UK where they have no services, they just have conversion therapy, to be honest. Denial of services in primary care. What this means is I needed to switch GP just to get blood tests. Just like in Ireland, pre-repeal, when we're talking about abortion, Irish trans people have a secret list of GPs who are willing to do blood tests. That's where we are. And because they're fearful that if they provide a blood test, that they'll get in trouble. Just a simple blood test. No, hey, how's my estrogen doing? For surgeries, you pretty much have to go abroad for almost all of them, and we're not following WPATH, which are the international code standards. Next slide, please. As well, we have very invasive psychiatric assessments, asking you really critical questions about masturbation, blowjobs, and other things which we know are essential to determining whether or not you're allowed to have some HRT. The same thing we give to cis women pretty easily. There's also lots of discrimination. So, for example, we have multiple cases of people who have chronic mental health conditions, or small chronic mental health conditions at all, and are on disability allowance for life, basically. Being told, go get a job if you want to get healthcare. This is, of course, a flat denial on the basis of disability, which is very much not on. Other cases of discrimination, example, the current free HRT scheme is launched out with many issues. I get it, My housemate doesn't. And there's a lot of confusion there. I think we've had 10 different TDs putting in PQs in this, several from supported. Because it's unclear, well, it's okay. Trans women don't experience the symptoms of menopause, which is weird because I could have sworn I had a lack of energy and focus 2.5 hours ago until I put some gel on, and it happened again in about half an hour. So just a misunderstanding in other situations as well. And of course, trans people have no involvement in any development of how healthcare is designed for us. Next slide, please. So the situation as well is over 2/3 of trans people are accessing healthcare abroad. We are exporting our problems. In addition, we are talking that almost 30% of people are self-medicating, DIY. So a similar sort of situation we're seeing in doxyprep and whatnot. And as well, I know people, several people over the years, more recently, who were with an Irish doctor or whatnot, and due to the quality of care, decided to switch to DIY. So like you can do harm reduction stuff if you can get access to blood. So here actually are some guides from Patty. So they also have to talk next. I know I dropped some of this into my local trans punk bar because it turns out a whole pile of trans punks are DIYing. Never really. But that's the sort of thing you have to do. It's like, hey, how do I read the bloods? If you can get them, make sure those people who are DIYing are supported. And people say, oh no, we don't know the medication source. And it's like, well, if you're so worried about that, prescribe to them. Next, please. So the National Gender Service. This was set up in 2018, 2019, outside of standard HSC processes. They approved and then wrote their own model of care, and they chose their own name. This is not an actual national service. Current waiting list is over 2,000 people, and basically people are being added about 3 times faster than they're being removed from the waiting list. And that's just going to keep on growing. They also opposed the conversion therapy ban, as it would hamper their psychiatric assessments, which is interesting. They also opposed the conversion therapy ban on the basis that it would make it impossible to develop a trans youth service. And also believe that you can't have a conversion therapy ban because they aren't actually trans youth, they're mostly just autistic and social contagion, which they said in the national media. Which fun. They also, of course, refused to engage with any trans groups, just unsurprising. They'll only talk to clinical groups about clinical matters, because obviously trans people, we don't know anything about trans healthcare. How can we possibly know anything, either socially or medically, about it? Next slide, please. And then last year, when I was in front of you in a different room, I was saying that the HSC for years had not talked to trans people about trans healthcare. Like they did not ask us before setting up this new HSC gender program. And I predicted that we're not expecting this to change and that any involvement would be tokenistic. So not much has changed. The gender program has been running for over a year now. They have had not a single meeting with the trans community about what the trans community wants and what we would like our model of care to look like. They've been very busy doing everything other than talking to the trans community, though. They've chosen their research questions, they've started 2 systematic reviews, they've started a clinical advisor group with secret membership. They aren't going to say who's on that. And they have lobbied for expanding the National Gender Service and giving them more resources. So it's lovely to see that impartiality. Next slide, please. And just talk more about those systematic reviews and the plans they're going to do for what they call the experience base. So that's talking to people. So who are they going to talk to? What are their questions? Their questions are about clinical needs, clinical outcomes, clinical needs importance for families and caregivers, and the experiences of healthcare workers, particularly GPs, of clinical needs. You may notice a few gaps in these questions. Questions that are missing are, what are the experiences of trans people? What model of care would trans people like? Why do so many trans people go abroad or DIY? What models work well in other countries? Because, you know, we can copy good models from other countries. I know it's difficult in Ireland sometimes. What are the ethics of the different models and how do we respect bodily autonomy? These are the questions that should be asking, but no. This is a clinical matter which will be decided by doctors who know best. Why would you ever want to talk to the actual patients? Next slide, please. There is, however, potentially some good news. So I was at HSC conference last week, and Bernard Gloucester there got a question in. And it appears that 2 weeks ago, Minister Jennifer Carmichael-Neil, Minister Mary Butler, Dr. Colin Henry would be over the programme, as he's the Chief Clinical Officer, and Bernard Gloucester, HSC CEO, had met to have an honest conversation about the gender programme. So this is the new transgender model of care. And it kind of sounds like they're not too happy that it's focused only on a medical model and should also kind of look at a social model, which I presume he meant a informed consent model we're asking for. Hopefully we'll see results soon. We'll see how it goes. Next, please. So let's talk about what it is that we would like to see. because, you know, it'd be nice if someone listened to us for once. Next. So what we want to see is an informed consent model. We want it in the community in primary care. So that's in GPs, in sexual health centres, like it is done in other countries. With ICD-11, the being trans moved from being a mental health condition, from being a disease, to being a sexual health issue. We want to be a co-production of the trans community because, you know, we want it designed for us. We want an affirming approach for youth. We don't want conversion therapy. Or, you know, because they look at saying at the UK or the US, things are looking at tad genocidal for trans people. Let's not follow them. And of course, bodily autonomy is important. As was said earlier, just as people want to keep on having sex rather than abstinence, we kind of want to keep on being trans and living. So we should be able to decide for ourselves what we want for our bodies. Next slide. And that, of course, is based on informed consent, which is how most healthcare works. You say, okay, here's the risks, here's the benefits, and the healthcare worker, who might be a GP, might be a nurse, might be a gynecologist, just facilitates that. Make sure someone's informed and they can make a decision. And it turns out you can do this in as much time as it does for a cis woman for menopause. Because at the end of the day, it should be a decision of the trans person. It's basically, okay, here are your options, what works for you. And that avoids all these denials of healthcare for irrelevant reasons, such as being disabled, or, you know, being straight, or being gay, or being bi, or being non-binary, or being autistic, which is, of course, the worst sin. Because we all know that autistic people can't possibly be trans. Actually, it's about 7 times more likely. Yeah, no, those are the stats. All this fear mongering about autistic people not being trans, if you're autistic, it's more likely that you have you're trans or gender diverse. So it's utterly drawn around. So some examples of good systems we can copy. Next slide. The Transat Clinic in Catalonia has been running since 2012. They would very much like to apologise for their 36-day waiting list. Yeah. It's got 8 centres spread around Catalonia. And it's informed consent clinic. It also does trans youth as well. And patients there are happy. They don't, you know, organise protests in front of the various organs of the health system. And next slide, please. Also, earlier in the year, myself and others from our committee went to Iceland and visited their gender clinic there. And also just to check that, you know, while we're hearing everyone agreed, we also talked to their National Queer NGO and of course their National Trans Group. And yeah, everyone agreed, which is good. So basically they switched to an informed consent model about 2 years ago. They had a 700 person waiting list. They no longer have a waiting list at all. This system's much more efficient because in total they've got about 4.5 people there, and it's nurse-led service with half a GP. And they are starting about twice as many patients a year on HRT as the NGS would be, with 1/3 the staff. As it turns out, it's far more efficient if you don't have to spend multiple days of clinical time deciding if someone's life is perfect enough to be permitted to have access to HRT. Far more efficient to provide people with information and let them make their own choices for body autonomy. Another thing is because it's informed consent service, people are willing to be honest about their health care, about their worries, about their concerns. If you have a pathologized, gatekeepy psychiatric system, if you say, oh, I'm not sure, or oh, I'm autistic, or whatever, you might not get healthcare. They might tell you to go away and come back in 5 years. In this sort of system, there are a few concerns that can be addressed honestly because you know at the end of the day, it's your choice as to whether you go ahead, so you can be honest with this. And even through the service I chose myself back many years ago, I knew that I could be honest because I know I was getting healthcare anyway. And as well, that the gender clinic and the community have a good relationship. They regularly talk to each other. Like we went out for dinner with them. That would be inconceivable in Ireland. So I would say to you, like, look at this sort of model, how we can put this stuff in GPs, in sexual health centres, and other ways to get forward. So thank you.
So my name is Lance. I'm a pharmacist at the practice location in Health in Ireland. So I suppose last year we were talking about you know, that and the stuff. So thanks for having us back. So this year, you know, like we've made it, we've done it, we have it here. It's a broad range of professionals, people that are supporting trans people in all different kinds of capacities. And we're here to talk today, I suppose, the training that we've been working on. So you've seen for the previous slides, look, we have serious issues here. You know, I suppose there's a lot of doom and gloom right now. Just it's trying to figure out, okay, what's the first step in trying to fix this, trying to change this. So we've seen, you know, alluded to there, I suppose, that kind of primary care, sexual health centres. We'll touch on that again, but education, it's sitting people down, talking with each other, finding what works, what doesn't. And you know, just getting started on talking this out. So we've got kind of two hats here, I suppose. I have kind of my provider hat, my trans community member hat as well. So on one hand, you've got providers that are saying to us, and this is in the literature as well, time and time again, you know, they want that confidence built, they want those competencies, and to be able to kind of navigate these little clinical situations that are arising. And then on the other hand, you have in the community, you know, I suppose, like, you know, we're not listened to, we're not trusted. There's that historic, those historic difficulties. So the end result here that we can get is somewhere where we have, you know, happy patients and happy providers, you know, good relationships between the two. Next one, yeah. So we split the content up into 3 modules. So we've got our foundations, intermediate, and prescribing. So foundations covers, first of all, your kind of communication, building a good environment, kind of how to be an ally and step up for trans people. And like, you know, that kind of principle-based healthcare, because we apply that to every other area of healthcare, every other patient cohort. But I feel like maybe when it comes to trans people and stuff, if we kind of harken back to some of those, it can help us figure out, again, how we navigate our situation in front of us. We carry that through into the more clinical modules like intermediate, we'll be covering everything that's kind of not related directly to prescribing HRT. So there's a lot of sexual health stuff, there's a lot of bits and pieces. And then, as you said, our prescribing and blood test, HRT, long-term follow-up. So really, we're going to be covering or really focus on the Republic specifically. That's where most of our members are, and that's where I suppose a lot of the identified problems are specifically. 3 parallel case studies we're going to follow along the way. So if you look at a person, you know, holistically, there's a lot of aspects to someone's individual care. There's, you know, like we said, with our foundation, setting up with like an environment, comfortable environment for them, that they feel that they can trust you, you know, dealing with kind of miscellaneous little queries come up for them and for you, and then moving on to kind of just, again, getting our hormones. So we have 3 designed, and I suppose the idea to have interactive means improve retention. And, you know, again, talking it all out for those of us who are on the ground, what is working for us, what's not. Really, again, we need like proper co-production working together. It doesn't work unless we have pulling these both perspectives of what are trans people facing, what are providers facing. So we draw an insight from that, and that was open and happy to submit, but we still welcome, like, grab us as we're around. You know, we want to hear about. I'll talk again about joining party and stuff, so you can put in anything that you want to know. Currently still being developed. So the other thing is we talked to, I suppose, other countries that have done this well. Talk about that in a second as well. You'll remember from last year, I'll harken back, you know, our international gold standard guideline, WPATH, intentional flexibility built in. So you can hear that imperative right there for the need, you know, it's like a need for local guidelines that adapt to the Irish context, fill in the blanks with other guidelines that are available for the different topics. So our foundations, really, we're looking at, really, every time we talked about the countries, what they were saying is, look, we should do all this technical knowledge, but at the end of the day, what we have to keep coming back to is kind of being able to how to communicate with someone, how to make them feel comfortable, how to, a lot of the time is one of the biggest things that we've come across. You know, because, and that again links in with, you know, that we don't want to skip straight ahead to the clinical stuff, because if we like to skip straight ahead to the clinical stuff, you'd be going, oh, well, look, I'm the doctor and I know everything. And, you know, it's that cultural humility. It's, you know, as a provider, it's being able to take a step back. It's difficult. A lot of the stuff, it's very easy to say in theory, but when you're actually out in practice, it can be difficult to apply. But it's, so we'll go into some more of these principles now. So as you can see here, we've a lot of kind of topics we want to cover, but these principles will stay the same the whole way along. So trauma-informed care means just, nobody's falling out of bed saying, oh, I'm going to stroll down to the clinic, I want my hormones today. It's a long process, right? Because there's a process of building up those concepts within yourself, verbalizing them to yourself, verbalizing them to the people in your circle. There's all these different processes. So the person that's had to get to your door, they've had to fight to get there. So that kind of understanding of, okay, it's not, this isn't just the exact decision. A kind of person-centered care that we're focused, like we said, it's someone's holistic well-being, like it's an individual, having an equal partnership relationship. The person on the other side of the table feels listened to, feels engaged with, that their needs are as important as maybe some of our more provider kind of centered needs, where we might be thinking about more prevention, stuff like that. Cultural ability, we talked about harm reduction, the bare minimum, really, like your kind of blood tests and some prescribing, because we have Jess has shown our blood test guides. There's some more with me as well. If you want any, please take them. And just that it can feel open. And the people feel like they can ask questions. I felt in my own practice that's kind of what worked a lot, kind of getting to that stage where people feel that they can talk to you. So it's what the intermediate then, with just all these little clinical queries that come up. Again, that we found on the ground, that we found in the literature, but also in our gold standard guidelines. So, like we said, again, trying to balance that, someone, patient can come into you and might have different priorities on their mind. And I remember they had it at the, it was the, one of the Safety Net conferences, I think, Street Medicine, what they were saying about, but the best way is to engage with groups if you kind of start and saying, okay, what do you need from me? That kind of way, like, that's how you build trust. That's how we start fixing all these problems, get people engaged for other services. So I think there is a lot of sexual health here, right? And the answers to a lot of the sexual health questions are yes, you can. It's great. With a few little caveats, a few little cautions. A lot of stuff, but a lot of times it's just knowing where to look, knowing where the guidelines are, that you can find them, find this information to support your practice. Kind of what you're doing. So with lastly, prescribing, in our, I suppose, again, gold standard guidelines, what do they say? It's that we need the choice of both primary care and sexual health. GPs and sexual health. For some people, it makes more sense to roll everything into one, with some people don't want sexual health services as much. So really, what we hope to kind of get to the stage that we're, that there are those kind of options for people, that we can see people can get care where it's accessible for them. So, you can kind of even moving from bloods to transcribe and to actively prescribe it. It's kind of, you're building up your confidence in seeing other people's prescriptions. I really break that provider level stigma, because there is such a stigma that carries on to the provider level as well, in terms of provision of this care, So, we have our steps here for prescribing, are different, we won't go into it. Really what we want to know from you is, what would you like to see to trade? And is there stuff that you've seen in your practice that, if you don't ask, you don't get? That's what I always say. Look, so just ask, join Patsy, and then you'll to be the first to find out about all this trading and stuff as you need it. And thank you again for.
Thanks very much, Siobhan. I'm going to take over for the rest of the afternoon, so I'll kind of see you through this later sessions. I'm Peter Keogh. I'm a professor of health and society at the Open University, both in the UK and in Ireland, based across all two. Background in community-based research in HIV and sexual health and reproductive justice and all of those lovely things. And we have a really nice, I think, last session basically for you, which is going to focus on the new National Sexual Health Strategy, but we're going to precede this with what we normally, I think, have in the morning here, the clinical update, because I think it can really focus our minds around the strategy. And then after that, we'll have a panel to talk about the strategy, which I'll discuss more. But I'd like to welcome Professor Fiona Lyons, and who's now knocking over glasses, generally causing mayhem, to give us our clinical update, and then we'll move into our panel. Thank you, Fiona.
Wreck the place anymore. It should work a bit great. My slide, I am perfect. So thanks for the invitation to present this afternoon. Yes, it is usually in the morning that I give the presentation. And first, the other thing I'd like to say is thank you very much for a new autumnal coloured lanyard. I love it. I actually just this morning threw out the one from 2 years ago because it was really represented significant infection prevention. But I loved it. So thanks again, thanks for the invitation to speak today. I have quite a lot of slides, so hopefully I'm going to get through stuff. But if I need to hurry on, please prompt me, Peter, or whoever needs to prompt me to get going. So I'm going to go through some clinical updates, and given that that's my area of expertise, that's where I can speak most comfortably to. But our program is not just about the clinical aspects, it's about our education training, research, health promotion, and other aspects of our program, but I'm going to give some updates from our colleagues in research as well. So with that, I'll get launched on. So the clicker should be working. Yes, so I suppose the big update from last year is that thankfully we have our sexual health strategy published in June of this year, and I'm really glad to be part of that process and really delighted the Department of Health has actually signed off on it, and looking forward to the discussions we'll have this afternoon about that. So I'm going to go straight into clinical updates, and so I'm going to speak about the home STI testing service first of all, and this is a nice graphic of the change in figures, absolute figures between 2022 and 2024. So we can see on the top 3 bars that the number of people who are ordering kits has been increasing over this time frame. The next one is the return rate, that the return rate is also increasing, and the return rate now is running to about 75%, and that's what we expect a mature home STI testing service to look like. You can see the bottom bars then are the reactive rate. So what is the pickup rate from the further care from the service? And you can see that's going in a slightly reverse trend, and that our reactive rate has gone down a little bit, and it also is down for the first 2 quarters of this year. And that's something that we need to be very mindful of to ensure that we're providing a fit for purpose, cost and good value for money type of service into the future. So on this slide we have the Q2, Q1 and Q1 figures for this year. It looks like the number of kits ordered is going to be similar to the previous years. It's similarly increasing in previous years. Our return rate this year is around about 75%. Our reactive rate, as I said, has come down a little bit at about 8.7%. One thing I want to really point out to you here is on the bottom line, okay? So what I think the really interesting thing the pilot showed for us is that this was a mechanism through which to engage people in their sexual health care for the first time. 57% of the people who participated in our pilot back in 2021 had never accessed STI testing before. And you can see that remains the case now, where in 2024, 40.5% of individuals had not previously had testing. Now you might argue they didn't need it before, Fiona. There certainly is a proportion of individuals who didn't need it before, but it certainly isn't the majority. And whilst the service captures young people, it does capture people through all age groups. So this is very good. I think that's something that we need to leverage into the future with the service developments. That it's not just about, if it's a gateway for people accessing sexual health care, we need to bring it beyond just actually STI testing, that it can be a gateway for people to access other aspects of things that will promote, protect and improve their sexual health. The reactive rates from 2024, we know that between 2023 and 2024, a significant proportion of the chlamydia and gonorrhea diagnosis nationally are coming from our home STI testing service, and that is a good thing because we've got good ascertainment of infection, which is good. With respect to gbMSM specifically, there are important things in this slide that we need to be considerate of. One is that about 14.4% of individuals are gbMSM who are using the service. Only 24% of them are on PrEP. Why is that? Should this be a gateway to PrEP as well? Only half reports hepatitis B vaccination. Should this be a gateway to hepatitis B vaccination? And individuals had a significant portion of individuals who reported unprotected sex in the previous 5 days. We don't know what kind of sex it was, but they weren't, and many of them were not on PrEP. So then again, going back to the concept that this may be a gateway to accessing sexual health care. What have we done since I last spoke to you in Dublin Castle last year? We have interval STI testing for stable PrEP users introduced in our guidelines in the journey of making PrEP care easier and demedicalising PrEP care for people who are not really patients, and that they're trying to prevent something from happening to them, as opposed to having a condition that they need to have to be made a patient for. We've also established SH24 accounts, and what I really like about that, it gives you an opportunity. I always check out as a guest when I do online testing or do online shopping, which maybe I do too much of it, but I cannot check out as a guest because I don't want to have an account. But I do see merit in actually going in for this kind of a thing. It's like your file, and you have access to your file, and you can see what's happened. And I think within the service, if we have it this way, again, we can look to recognise individuals who may need more from the service by understanding, oh, this person's had syphilis 5 times, what's going on for them? Or this person still isn't on PrEP, what's going on? This person isn't hepatitis B vaccinated. So I think the establishment of the user account is very useful. And from a climate perspective, a major kit redesign, and you may have noticed this, that if you've ordered kits recently, and that there's been 80% reduction in the plastic used, and that was all down to SH24 trying to be sustainable and climate conscious. Last year we had just completed a pilot, and we just started about a month into managing low complexity chlamydia through the home STI testing service. That has continued to go very, very well. And now 77% of individuals in Q1 of this year who had chlamydia had it managed through the home STI testing service. This does a couple of things. It makes it easier for individuals. They don't have to go face to face. They don't. They can get the care provided within the context of the home STI testing service. It would appear that having to pay for the doxycycline, the azithromycin, hasn't been a barrier to accessing this type of service. I prefer if we didn't have that cost barrier, but right now we don't have that piece of the jigsaw puzzle solved. And we do know from a piece of work that was done by some of the SPRs and James's, comparing the time from diagnosis to treatment in the group who were managed through the home STI testing service versus people managed in the clinical setting, there was a significant reduction in this time. So from a public health perspective and from an onward transmission perspective, this is an important thing to consider as well. Pathways to condoms and lube. And I just this morning remembered sitting on the podium last year and somebody said to me condoms were dead when I talked about us. And you can all laugh, okay? We need to ensure we've got a full suite of tools available to individuals, and we introduced the pathway to condoms and lube through the home STI testing service in October of last year. For reasons of the weight and postal costs, and I kid you not, the current offer is that it can only be included in the gbMSM pack, because if it's included in other packs, it goes into a new weight category, and that sends the contract and the tender and the cost. Who knew having those kind of conversations? What we do know that when it was launched in the last quarter of 2024, 72% of gbMSM who engaged with the service ordered condoms and lube, and in the first quarter of this year, 71%. You might say they only wanted the lube. So we are actually going to look and see if that is the case, to determine if it is that they only wanted the lube, and because that's an important thing to know, that we're not actually wasting condoms. We want to make them available, and that is a questionnaire that's going to be submitted to users in the near future. The other thing that I know that I think it was 2 years ago I was asked about this, about user activated kits, because there are people who can't, for whatever reason, have the kit going to their home. Their wife, their husband, their lover doesn't know that they're actually having sex outside of that partnership, or they're living in a flat with 12 bed sets and a postman doesn't know how to get to them. So user activated kits, in partnership with the four NGOs, we've established a user activated kit. A lot of work went into understanding that, because if you think about it, when you go through ordering your kit through the home STI testing service, your kit is built based on how you answer your questions. We're trying to guesstimate in this situation how many of this kit will be needed, how many of that kit will be needed, and a lot of work with Caroline and colleagues in the programme and the NGOs to work out what different types of kit would be needed. So we're looking forward to the results coming through on that in the next short while. Moving now to HIV PrEP, and this is a very busy slide, but what I want to point out, and I'm not going to excuse the capacity and access issues that we have with PrEP, but is to continue to show that we continue to see an increased number of new people newly accessing PrEP. And this one here, 938 for Q1 and 2, 2025, and 930 individuals received a PrEP prescription for the first time. We need to see this increasing. That ascertainment of individuals getting onto PrEP is what we really need to see the PrEP service growing. And there are a number of capacity measures that we put in place in the last while, I'm going to speak to over the next couple of slides, that hopefully in Q3 and Q4 of this year, we will see this number of people increasing significantly. So Preptimize, love the name. It's not as good as Shift, and I know that Robbie they got the best name ever. So Preptimize is the Department of Health made an evidence for policy call in 2024, and under topic 8 they were specifically looking for strategies to improve value for money in Irish healthcare settings, in primary, community and acute settings, focusing on productivity, efficiency and sustainability. And I was reading through the document, I thought, I have an idea here. So we have partnered with a group in Trinity, and we have started recruiting their 2 sites in Dublin, Guy Clinic in Dublin and Vince's SIVUH in Cork. We started recruiting in Dublin this month, sorry, no, September, a month ago, and over 30 people have been recruited. We will start recruitment in Cork soon. And the objective of that is actually to, like through what you were talking about co-creation and co-design of services, is to pilot something and see what the perfect model would look like. What is the best way of doing this co-design of a hybrid PrEP service? Interestingly, I'll just share with you, not everybody wants to have a hybrid service. Some people place huge value in actually being able to sit across the table from their physician. And I think that's something that that the funders need to be really mindful of, that we need a jigsaw puzzle of ways people can access care. What else have we done? So in December 2024, after a long, hard graft, we launched the PrEP e-learning program. And if any of you do it, you'll see that there are some popular faces. And David is on it, Grania Courtney is on it, Grania Kelly is on it. And it's a module that's is now one of the core competencies that we want healthcare professionals to have before they become PrEP prescribers. Importantly, there's a cultural competency piece within that, and individuals are also asked to complete the HC and LGBTQI Foundation lesson as part of their competency. So how is that doing to improve capacity and access to and channels of access to individuals? By the end of Q2 this year, 36 approved GP PrEP providers, 18 of whom were approved in 2025 on foot of the PrEP e-learning module. Really importantly, they're not all in Dublin, because that's where they were all based before. We know the acuity and most of the population's in Dublin, but the need is not just based in Dublin. So hopefully this will continue to be a good mechanism through which we can improve options for individuals to access HIV PrEP. New resources were allocated through the National Service Plan 2025, and funding was way less than we had hoped it would be, but we did get 7 posts, and we've engaged with services to understand what the uplift is and what the value for money is associated with those new posts, to demonstrate that if you invest, you will get a return on your investment. And we have mechanisms in place for monitoring that. This is very complicated, and I wondered whether I should take these slides out. But within our standards document, we have worked with ECDC. Caroline and I worked in a group at ECDC to develop standards for PrEP care. We modified those standards within our HIV PrEP working group, and then we developed a monitoring and evaluation framework. So huge kudos to Caroline, Rachel and Sinead, who've done a massive amount of badgering of services to get all the data back, and also linking in with PCRS to get a really good monitoring and evaluation framework. So what I want to talk to you about on this particular slide is around coverage. So we know that uptake is increasing all the time, but are we getting the people we need to get? And how you would do that is to describe how many people who are currently using PrEP relative to the population in need of PrEP. So the numerator is the number of people who are on PrEP, who've had access to PrEP at least once during a particular reporting time, and the denominator is the estimated number of people who will be eligible for PrEP or who want PrEP according to PrEP availability within a given reporting time. That denominator is not currently available. So within ECDC, they come up with this PrEP to need ratio, which I will speak to on the next slide. And it is trying to understand, I don't have my glasses, I can't read the slide. So it's looking at the number of people on PrEP relative to the number of HIV infections that could have been avoided in a particular time frame. There isn't a standard, but the higher the better. So we have worked with colleagues in HPSC to get a good understanding of what our prep to need ratio is. We can't disaggregate this data the way we want to. It's based on reported gender. We don't actually have any more information at this point in time, and maybe that's something that in the future we need to have a better monitoring framework, but this is the best we can do with the information we have. And what you can see is if you look on the very bottom line of the table, the prep to need ratio in first time diagnoses where the likely country of infection was Ireland was 73.3 overall, but there's a massive reported gender difference here where it's 93.3 in men. Very significant majority of these are likely to be GBMSM, and within the female it's 3.4. So somebody potentially within this, it suggests that people are being left behind, and we need to address this and trying to get better data to inform who these people exactly are, and to see overall that our prep to need ratio continues to increase. And we can see that between 2023 and 2024 it did increase because we are continuing to get people on PrEP. What is the impact of PrEP? So we're starting to see an impact of PrEP in a reduction in the number of new HIV diagnoses, because that's what we're trying to do. And we're trying to, I know Johnny spoke to this earlier about getting to zero, and I'm really sorry that I missed all the great talks this morning, but I was in clinic, so I'm sorry to have missed the talk. But so how can we best do that? And we've worked with colleagues in HPSC to see if we have had a change in the number of new HIV diagnoses. And you can see that, since 2015, there has been a drop in the number of new HIV diagnoses. There are still data gaps, and I know there's a big project to improve reporting through the new OSIMS project in Ireland to improve data quality to get a better understanding. But the trend is down. It needs to be further down, but the trend is going in the right direction. So last year, I think we actually launched it on the day. That's exactly it. Yeah. So we had our guidelines and our information FAQ that was launched at Gay Health Forum last year. Since then, John and myself John Gilmore and I have participated in the guideline development group BASH, which was I invited myself. Was invited. But it was very useful, I think, for us because we're a small country. We don't have the machine to do all the data, the literature reviews, all the conducting all the PICOs that is needed to do this, to develop evidence-based guidelines. So we were very lucky to be part of that group, and it was very meaningful process. So the guidelines were published in June, and just earlier in August, I completed a comparison of where we are versus where they are, and I've sent this out to the small guideline development group that we will discuss in the coming weeks to see where we go in Ireland, to see what our position is in respect of doxypep. And I'm really sorry to have missed your talk earlier, John, about the survey that you did. I really want to know what still have quite a few emails that I haven't read. So this is a piece of work that we still need to complete around understanding what the position is. And I think talking about when you spoke about people doing their own thing, and actually I think we need to recognize that people are doing this, and we do recognize that people are doing it back to the days when we knew people were taking PrEP. So it's like, come on in, please, let's do this in the safest possible way. So I think having an honest and open conversation with people about taking doxypep is something that we have been doing, and hopefully we can do it in a more formal way with the new guidelines. Chemsex, within our GBMSM working group, how am I doing time-wise, Peter?
I would say you've got about 7 minutes.
So within our GBMSM working group, we had doxypep, access to PEP, and STI HIV surveillance as our 3 priority actions. Last year, we made a decision to include a new action around chemsex. And at our first meeting where we had that discussion, it was apparent that we actually really needed up-to-date information because there have been lots of reported changes in the type of agents that people are using, and there may be different needs and resources associated with change in agents that are being used. So we are now working with the Public Health SPR to conduct a survey that will be submitted for ethical approval this month, with a view to conducting a survey amongst people who may be using chems to get a better understanding of what they're using, what kind of resources they need. And also we've engaged with the limited resources that are available for people who are using chems to get a kind of a map of what's there. We know most of it is Dublin-centric, and we know that not all chems use and problematic chems use is Dublin solely based as well. So the National Condom Distribution Service was launched 10 years ago next month. which is around the same time as the strategy was. It's 10 years ago next month, and since since the condom service was first launched, we have multiple channels through which people can access condoms. And in this, the development for this year is that the GP prep providers can access the condoms for the people who are attending their services, but any GP can now access condoms. And so far in 2025, 24 GPs have signed up, and hopefully there's something, I know there's a webinar being done with GP prep providers and GPs very shortly, very soon. So this can be promoted hopefully through that webinar as well. Robbie, your picture of yourself in bed isn't meant to be bigger, but when I tried to make them all the same size, she failed. So just going to give, I'm going to move away from clinical updates now into sort of other aspects of the work that's been going on in the programme. And there are probably important pieces that I've left out, but I think this is one of the most socially important pieces of work that's been done for quite some time. And this co-created You, Me and HIV. I was in the gym. I think I sent you a photograph. I was in the gym one evening, and it popped up on one of the bus stops opposite the Phibsborough gym. And I sent Robbie, "You're in Phibsborough gym." Outside there. So from the beginning, this was a co-created campaign, which I think is what lends to its strength and to its success. And the reason for doing it is because we knew there is still far too much HIV-associated stigma in Ireland, and the objectives of the goal were to decrease HIV stigma by communicating the primary message that people on effective treatment cannot pass HIV on. And so that's been a very simple message, and it's been really lovely to be engaged with that part of that process. And we have the photographs out here the posters are gorgeous. They're really, really nice. So phase one has shown that there has been an increase in people's awareness and knowledge, and people are comfortable with the idea that people live more comfortable with the idea that people living with HIV on effective treatment cannot pass it on. And phase two has been launched, and there will be continuous ongoing evaluation. I have to say a huge thanks to everybody who's been involved in part of this, and particularly in no small part to the people living with HIV who have become their own advocates. Well done. And again, research updates. So Nicola spoke this morning, and I can see Andros in the audience there. Hi, Andros. So we really need regular general population surveys. They are huge things to do. They take, and Nicola will tell you how much planning they take. Andros will tell you how much planning they take. So we hope to get to a cycle of at least 5 year annual reviews of where we are to track how we're doing with improving sexual health outcomes for the general population. So it's great that this is happening. I know there's a ton of work. I've only got one slide in it, but it probably deserves about 8 hours of conversation because there's so much work going into this. And our data that we have right now is quite old, the data that we have on a general population level. And that has already been a challenge for us in trying to understand where we are now. Whereas 10 years ago, when we had the strategy, we had much more up-to-date. It was relatively much newer data. So it just highlights the importance of getting up-to-date, regularly done data. The other projects we could include EMIS, and hopefully we'll have the report for Ireland late this year, early 2026. Significant, not a huge amount not as big a cohort of individuals engaged in the EMIS cohort study in 2024 versus previous years. And I suppose that's going to make a challenge around the generalizability of this and the findings from it. And with respect to chemsex, we did look at the questions that were asked and to see would it help inform our chemsex response right now. And it won't, unfortunately, which is why we need to do a separate survey. And there have been sexual health. I know Nicola spoke to some of the surveys on young LGBT earlier today, and other surveys looking at parental sexual health communication in young people with intellectual disability. And this is something that's particularly of interest to me as a parent of an adult with intellectual disability, where there is no support for parents with adults with intellectual disability, and they do have sexual health needs. So I'm delighted to see this work going on. Education and training updates, thanks to Moira and Quiva, further updates here. So we have our co-developed LGBT plus training resources in the know, which is now being hosted by BelongTo, and the HSC Land LGBT awareness and inclusion has had 18,000 completions since it was started in 2019, and there's an overhaul planned of this in 2026. And the sexual wellbeing and intimate relationship for lesbian, bisexual and queer women, which was developed in co-creation with Sexual Health Centre and Link and Cork, has been reprinted this year as well. Finally, and the sexual health promotion training continues to. There were 14 Sexual Health Foundation programme days in 2024, 7 training days for the working safely and effectively in sexual health promotion in 2024, and the sexual health promotion signposting workshop for professionals and working and for veterans working with international protection applicants has been extended beyond the pilot phase, which is really, really important to ensure that we can, because we know that people have lots of questions, and we need to ensure that the people who are meeting them have the information that they can provide to them. A huge amount of work has been done with Education and Training, Department of Education, NCCA, to develop the senior cycle in RSE, and continuing to develop our resources for parents around making the big talks a series of small talks, and demystifying the discussion about sex. My mother, when she gave me my first sex talk, closed the curtains in the we weren't overlooked. Might be able to lip read that she's so thank you on that. I'd just like to thank you all for the opportunity to speak.
You did so well that we've got 5 minutes time for questions.
I don't think I said condoms were dead, by the way.
No, you didn't. It was somebody else who wasn't here.
I said something else.
No, you didn't say
A
condoms.
couple of things you may have picked this up. With the SH24, what proportion of reactives do we have in non-attendance and follow-up?
Yeah, we were actually I know top line, and we actually had a meeting about it yesterday. So it's small.
Okay.
So if you look at the evaluation report, that actually gives more detail on it. There's not a significant difference between what the pilot evaluation did and the 2023 and 2024 data shows. But I haven't, the document is due to arrive. We had a meeting with SH24 about that yesterday.
And then just a couple things. Could chlamydia treatment, could it not be linked to, is it a funding issue? Because like with the drug payment scheme, you'd imagine that it's a similar idea. If someone has a drug payment scheme card, they should, like their HIV PrEP reimbursement.
It isn't going to reach the threshold. It's way less than the threshold. So the threshold for the payment scheme, you'd have probably about 10 courses of doxy, I think. It's about a tenner, I think, I'm not sure about the dispensing fee associated with it. That's what we've been told, it's about a tenner. So I'm not sure. I know we're going to talk about the strategy next, but I think like Mark 2 has to be about equity, meeting people where they are, breaking down barriers to build on the foundations, the massive gains that we've had in the first 10 years of the strategy.
Just a quick clarity on the ChemSec survey. Is there PPI representation of people who are actually using chems? Because this has been reported internationally that people say that there's PPI, but they tend to be the type of people who frown very much on chems users. So I just
I don't want to.
That's fine. I would think, but there are. Yeah, that's great.
Do you want to?
So they can't give the specific details. So it's different. There's definitely people that it's difficult as well in terms of people, I suppose, identifying their needs. But I can chat to you afterwards.
But a lot of engagement, and the survey isn't signed off yet, and so the survey will be discussed at the next gbMSM, which is a multidisciplinary.
Just a comment. I think when you're talking about SH24 and the LGBT condoms attacks, I've been doing a project in Cork anyway where we're distributing condoms via bedbox. So what you've realized is more like people are using condoms more, they're taking condoms from our bed boxes rather than loops, which is kind of interesting because I think maybe you just mentioned that maybe when people are ordering condoms, they just want loops. But our findings just like people are taking condoms rather than loops, and we're questioning like what's really happening. Is it like there's more oral sex, or I don't know, but like it's more of.
That's really interesting to know because we were wondering that just yesterday. What is the pattern of ordering from the NGOs who have a postal service available for condoms and lube? Are people placing orders more for condoms and lube, or lube on its own? So that's really interesting. We'll definitely
just to
more
be
about that.
specific, it's just for the cruising sites. It's not from
which sites?
It's from the cruising sites. So yeah, sorry, you missed the presentation.
Yeah, sorry.
Yeah.
Thanks so much, Fiona, and it's just such a huge amount of work with, especially with the model of care that's coming online pretty soon. And I think will really help to crystallize what we, want to grow in terms of the workforce from a sexual health perspective. And someone mentioned earlier about people who are trained in sexual health to understand the nuances of that and the urgency around some of the things that you're speaking to. So that's it's just such a big piece of work, and thank you for doing it.
I mean, I think, like, so the first time that I felt really, really challenged around cultural competency, and then this is much of this is around cultural competency, and it's a little bit like the values discussion that people who provide termination of pregnancy services is. The first time I felt really challenged was back in the late 90s, early 2000s, when we had a massive increase in the number of people coming from overseas seeking care, and I was looking after women living with HIV who were diagnosed during pregnancy. And I was like going, you need to do this, 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 and this. But there was so much that I was missing because I didn't understand the healthcare structure in which they had previously accessed care and those kind of things. So I think in developing any model of care, we can say where we want it. It's really important that people have an opportunity to say where it is, but you also need to make sure that those are providing, like, sexual health care provision is not for everyone. There's some people who will run a mile from talking to people about their sex lives, and there are some people who are very comfortable about it, and we can't force that upon people. So I think we need to ensure that anybody who engages in it has the cultural competency to provide the services.
Right, thank you. Panel members to join us on the dais, I guess what you might call it. So yeah, for the last part of the session today, we're going to have a panel session to talk about the new National Sexual Health Strategy, which replaces on, and as you all know, builds on sexual health strategy, which ran between 2015 and 2020, but obviously was extended through the pandemic. And the document itself also contains a sexual health plan, an action plan for the year 25 to 28, the first of 3 action plans. We have 5 great people to discuss this with great insights, I'm hoping. First of all, I've got Professor Ellen Crochelle, who's the Deputy Chief Medical Officer and a paediatrician at Children's Health Ireland. We've got Verena Tarpey, who's the Chief Executive Officer of GOSH in Limerick. Robbie Lawler, who I'm sure you all know, an HIV activist, advocate and academic and podcaster. And Pádraig Rice, who's a Social Democrat TD for Cork South Central and chairs the Dáil Health Committee. And then, of course, Professor Fiona Lyons coming back to join us, Medical Director and Clinical Lead of HSE Sexual Health Programme. We're going to start with a 15-minute presentation from Professor Crochelle, who's going to take us through the strategy. And then I'm going to ask everyone to just spend up to 5 minutes responding, because what I really want to do is throw this open to the floor for robust but respectful and constructive discussion about the strategy itself and where it is going to take us. So, Ellen, if you wouldn't, that's great.
Hi, everybody. Thank you very much for the kind invite to speak. So I'm a Deputy CMO at the Department of Health. I'm a relatively new recruit, and my background is paediatrics, so I'm very much here to listen and learn as well. But there are people who've been very involved in this strategy from the outset, so who if there are questions that I can't answer, that they will absolutely be able to help with, and I can always bring that back to the department. So as you'll be aware, the National Sexual Health Strategy was launched this year. The new strategy has a 10-year lifespan, and it'll be supported by 3 action plans. The first action plan is in fact included within the document and includes actions that will be put in place between now and 2028, and that's a very important point because lots of strategies are developed without action plans, so it's great to have something to hit the ground running with. The strategy has been developed in collaboration with a wide range of Department of Health policymakers, HSE service providers and clinical experts, with input from lots of government departments and various stakeholders. So this strategy builds on previous work of the 2015 to 2020 strategy, and with the goal of learning from the previous strategy, both midterm and an independent final review allowed us to assess areas where things went well and where things could be improved. Now, the review was independently done by Crowe in 2023 and found that, in fact, the first strategy had been pretty successful with 49 of the 56 actions deemed to have successfully progressed. So the strategy development process was delayed by the pandemic. So the original one was to finish in 2020, but ran through. So the drafting group for the new strategy was set up in 23 and included an additional round then of stakeholder, clinician engagement and consultation and feedback. There's a list of the stakeholders and partners, and you know, there was a wide range of parties. Parties include lots of government departments, agencies, service providers, etc. And I can put that list up again a little bit later. So I guess that the sexual health strategy is part of a wider policy ecosystem. It's not in isolation. It sits under the umbrella of the Healthy Ireland framework, which aims to support us all in maintaining and improving our health and well-being generally. It also supports our Women's Health Action Plan and HSE's Men's Health Action Plan. The Healthy Ireland framework itself is being reviewed at the moment and is being renewed at the end of its term. So both the sexual health strategy and Healthy Ireland in turn form part of the Sláinte Care Healthy Living pillar, and tackling inequalities is absolutely part of progressing Sláinte Care. There are lots of links to other strategies, included the ones here, including the second LGBTQIQ plus inclusion strategy and the justice sector zero tolerance strategy. So the first strategy you'll be aware of, and I think there are some direct achievements, including the condom distribution service, the STI testing, building sexual health promotion, education training, and HIV prevention initiatives, and pelvic cancer survivorship initiatives. So they're all direct achievements of the first strategy. And I guess, you know, things were helped along by wider policy changes and societal changes, including the marriage equality referendum and the repeal of the 8th Amendment to the Constitution. So the vision for this strategy is as it was for the first strategy. In fact, it is that everybody in Ireland experiences positive sexual health well-being and has access to high quality sexual health information, education and services throughout life. However, we will be very much broadening and deepening what we deliver under a successor, providing more of the right care in the right place at the right time on the basis of need rather than the ability to pay, and that's absolutely conforming to Sláinte Care principles. The sexual health strategy has 4 goals, and those goals broadly support sexual health promotion and education, covering work with the education system and information campaigns and resources. I'll go into these in a little more detail in a minute. The second goal is supporting sexual health services, the public network of 23 STI clinics in partnership with the community and with primary care, contraception and unplanned pregnancy, working with primary care, GPs, family planning and student health clinics, and with pharmacies to widen access to condoms and prescription contraception. It also covers partnerships with maternity, gynecology and women's health services. And the fourth goal is around surveillance, monitoring and research regarding sexual health generally, HIV and STIs. The strategy is underpinned by 6 key principles. These are positivity being number 1, and I think it's great to see that there. Positivity is really recognising that sexual health is a key part of the life cycle, supporting the positive and life-affirming aspects of key relationships in our lives, as well as avoiding negative outcomes such as infections or unplanned pregnancy. The second principle is diversity, equality and social inclusion, which you know, I've heard repeatedly mentioned here this afternoon. This is key to ensuring that everybody feels able to access care if they need to, free from stigma and shame, and also on the basis of need rather than ability to pay. We are working with HSE National Social Inclusion Office to provide additional support for minority communities as well, and around translations, interpreting and support for victims of violence, amongst other things. Working together in partnership, collaboration being another key principle. The strategy takes a systems approach in working across government, the health services and community to support its goals. With the support of the Department of Foreign Affairs, we're working to progress our international commitments. These include things like UN AIDS and WHO targets to eliminate HIV transmission by 2030 and the broader sustainable development goals. And the last two key principles are around training, empowering and upskilling our healthcare staff and supporting the development of more effective, people-centred and integrated care over the lifetime of the strategy. So just touching on the goals in a little more detail, the first goal, and we've heard some of this already through the HSE work, first goal is to create a cultural and legislative environment in which sexual health and well-being can flourish. So those are the overall aims, and examples of this include sexualwellbeing.ie website, public information campaigns including You, Me and HIV, which we've just heard about. It also covers work with Department of Education and Youth and teacher training supports to IDGE. We provide materials for use at home too for people who have children, teens and young adults. We're working with HSE Social Inclusion and CUAN to raise awareness and understanding of consent also, which should be mentioned. So in terms of the sexual health services, which is the second goal, this covers the work that we do through the National Network of the STI clinics, through community partners and GPs, family planning clinics and student health services. The Minister will have mentioned some of these earlier on. Suffice to say, we'll be working with the HSE and other partners to deliver models of care for HIV and separately for sexual health, and to draft an action plan for HIV in addition to other services. We are aware, as Fiona touched on, we're determined to continue to listen to our stakeholders who have highlighted inequitable access to services and clinical capacity and wait times as key concerns. Then the third goal around contraception and unplanned pregnancy. So free contraception, as you know, is now available, and the National Condom Distribution Scheme has proved to be quite successful with the numbers of over 500,000 condoms distributed to NGOs and almost the same number to third level in 2024. So there's been significant work and associated progress in this area. So sexual health surveillance, monitoring, evaluation and research. So I think we've already seen some of the exciting projects that are underway. And we have lots of surveys and different sources feeding into that. So there is, sorry, just keeping an eye on notes. There's a significant amount of work going on to support specific healthcare needs across the genders. We've done a lot of work in recent years to support the HSE Men's Action Plan, most recent of which was launched in 2024. The work is widening to include sexual health related matters such as domestic, sexual and gender violence based violence prevention and pelvic cancer survivorship plans. Those pelvic cancer survivorship pilot projects are running at St. James's and Cork University Hospital, and they're just starting off. The department's women's health action plans have delivered a lot. There's been free contraception, period poverty and dignity, and free HRT schemes are also included. The free HRT scheme launched this summer. Over 180 million has been spent on women's health since 2020. It includes a wide range of gynecological supports. Finally, while this is much wider than the sexual health strategy and outside the scope, and as we've heard from Jess and Chevelle, work is hopefully progressing, and with the HSE and the Minister is very much involved in developing a model of care for transgender healthcare, and that will hopefully progress. As we all know, for policy to become action, strong implementation and governance structures are required. So this is the mapping out the governance structure. So there's an implementation oversight group, and who will be advised by a stakeholder advisory group, and there will be 4 subgroups. The implementation group has met, and in terms of reference and that are being agreed.
So the next step is action, and the first of the 3 action plans has been published and it's available to view online. The overall aim is to provide and support a more accessible, seamless delivery of sexual and reproductive health care over time, and as restated as launch care commitments, right care, right place, right time, based on need and not ability to pay. So finally, a big thank you to government, to health service and community partners. It couldn't be done without you. And just to flag to all the collaborators that are here today, that once the governance structures are up and running, we hope to hold a stakeholder forum in the new year and reach out to the community partners to submit feedback, new trends, or anything else you feel the policymakers should be aware of. So please do watch this space. The strategy is available on gov.ie website under policies. Thanks to everybody. Thank you for the kind invitation to speak, and thanks to Fiona Manser, who does a lot of work in this area.
Brilliant. I thought that was absolutely spot on. Thanks very much. Thanks very much, Ellen. So now I'd like to just ask our 4 respondents to just speak for a few minutes on what their reflections and responses are, the challenges around the strategy before throwing it out to the floor. And I suppose I'll just kind of go along the row really here, and I'll start with Pádraig. Thanks, Pádraig.
Thanks very much, and thanks very much for the invitation today. Just want to start by thanking everybody for all of your work that you're doing in terms of sexual health and well-being. I know how committed everybody is, how hard everybody works, the innovation that's happening, and it's really great to see. In terms of the strategy, it's really great that we now have a strategy in place. It's something that we have been calling for, and I think I have been quite critical of the delay in terms of the strategy being put in place, but it's great that it's now there, and there are many positive elements to it. I think we could all agree in terms of elimination of new HIV transmission, better access, and improving access across the board. I suppose I just want to touch on a couple of points over a couple of minutes, just around implementation, funding, and access to services in particular. I think what's most important from here on out is the implementation of the strategy. I think as a country, we often suffer from implementation deficit disorder. We're really good at writing great strategies and reports. We're less good at implementing them. And I was here last year. I spoke about some work I did around the national LGBTI strategy. I spent 6 months of my life going through the strategy painstakingly, looking at all of the actions and how they were implemented, to discover that some of them were fully implemented, some of them not at all. And we graded those from A to F in a project with LGBT Ireland. But what I learned from that is that difference across different services and different parts of the state are sometimes very good at doing the strategies, and others completely fail to implement things, and in particular, real failings around trans healthcare and intersex rights, in particular, getting Fs across the board in that report. So I think we have to, both as a community, but also as a political body, in my role as a TD and chair of the Access Health Committee, put a focus on implementation and hold the state to account to implement the plans and the promises they've made to all of us, and keep that focus on it. And I think in politics, I often find there isn't too much of a focus on sexual health. I think it rarely comes up into all debates or in parliamentary questions, and there's very few of us who seem to mention it. I was told an anecdote once by somebody who worked for a now retired minister, who was responsible at one stage for equality. The civil servant was drafting speeches for the minister and included references to sex and sexual health in the speech, and they didn't get mentioned. And then the next time they did it again, and there was no reference, and they went to one of his special advisors and said, "Oh, what happened? Did the minister not get the right speech?" And the advisor said, "Oh, the minister doesn't say sex." So we do need to ensure that our politicians have a focus on these and do implement these. Linked to that, and I suppose crucial at the moment, is as we head into budget in the next couple of weeks, is around funding. And as I said, I don't think sexual health has ever been a priority for the state in terms of funding. And I think sometimes I'm critical of these strategies because they don't link the actions to funding. You often see sometimes vague language around striving toward, exploring, considering, but rarely do you see concrete action with a timeline and with a budget. And I think that's what you need. And you need to have the funding linked and the funding secured in line with the commitments in order to get them done. We need to ensure that there is adequate funding for these services, and it's something that I've been raising. The final point then, I think, which is key, is around access to services. And in particular, I'm quite concerned about access across the country. And I think I often remind people that only 25% of the population live in Dublin, 75% of us live beyond Dublin. But there are 10 counties across the country that currently do not have a public health sexual clinic. So you have counties of Cavan, Kildare, Kilkenny, Leitrim, Longford, Meath, Monaghan, Offaly, Roscommon and Wicklow do not have a public health sexual health clinic. It's quite stark, like the 10 counties across the entire country with no access to a public sexual health clinic, and that concerns me, particularly given that 75% of us live outside of Dublin. I think we should be worried about that. Similarly, in terms of access to PrEP, I've been submitting parliamentary questions to the Department and HC around waiting lists and access services, but when I got back in June on PrEP, showed there were 862 people on a waiting list for PrEP, and those waiting times were between 3 months to 12 months, depending on the different clinics. So huge number of people on the waiting list, and then also quite significant waiting times as well. So that definitely concerns me, and also concerns for access to these services for the most marginalised parts of our community. And I think we need to think about that, particularly when for some things you need to online access, and thinking about in-person services in particular. And as I said, I'm very concerned about trans healthcare, and I think we need to, in terms of these strategies, link trans healthcare into some of these strategies in order to get it delivered. And I think it would have been good to see a focus on trans healthcare in the sexual health strategy. I think that would have helped us advance a case on trans healthcare. And I think we need to ensure that there is funding put in place for the new model of care for trans healthcare, and that needs to start now. Can't wait until the work is done in the Department of Health for that. I think in this budget that needs to be done, and it's something I intend to say to the Minister in the Dáil next week. That's my thoughts.
Thank you, Paul.
Hello everyone, back again. I just want to, I'm grateful to be here to give reflections, albeit 5-minute reflections. One of my favourite lines in this whole national sexual health strategy was page 59, the very top, radical listening will be enabled. And I remember highlighting it like 10 times. So I was like, this is fabulous, because if radical listening is enabled, well then radical action can happen too. And that's what we need to address the rise in STIs or to meet our targets of zero HIV infections. So I'm looking at this national sexual health strategy through the lens of someone living with HIV and as a gay man. So that's what I focused on, particularly in doing this. I really love that you called it a living document and that it's adaptable. I'm looking at you, Fiona, I don't know why, but that's living and adaptable. That's really, really important going forward, considering some of the things that I'll be talking about. When we talk about radical listening, 5-minute reflection on an 83-page strategy is very difficult. Like, you know, as you were talking about each bullet point, we could talk about this for hours and hours and hours. For me, just to give it an overview isn't radical listening, actually, and from the conversations we have. So that would be one point I have going ahead. But before I share some of my reflections, I really just want to acknowledge and congratulate, and this is something I don't really do, but well done, everyone. Like, well, there is so much to be proud of here. There is so much. Like, it is undeniable for the LGBT community, our sexual health has changed dramatically over the last 10 years or since the start of the last national sexual health strategy. In many, many incredible ways. The sh24.ie, oh my God, one of the best things when we talk about people in this community, how much this is transformative. Did it take a global pandemic and the closure of sexual health services for 2 years to really expedite it? Yes. But did we get it? Yes. The free contraception scheme, amazing. Were we banging our heads saying we want everyone at reproductive age to gain access to this? Yes. But we promised this, and hopefully this happens as soon as possible. And the You, Me and HIV campaign. So if you can divulge me for a little bit, it's truly incredible. I could never have imagined in a million years that there'd be a nationwide campaign of out people celebrating that we can pass on HIV, and we can have kids live for passing on HIV, and we have women represented living with HIV. It is truly incredible. And talking about truly incredible women living with HIV, I just want to give a big shout out to the lovely Emma McCartney, who came all the way from Glasgow and who is part of the Positive Tribe. I highly recommend listening to the podcast. And she's represented in Stephen Dial's amazing exhibition out there. So thank you so much for coming here, Emma. absolute amazing activist based in the UK. We need more nurses here in Ireland, so come over and live here. Yay! So yeah, I just really want to highlight the power of community. One thing that I really think that this strategy really needs to do when they talk about community partners is differentiate between NGO and actual community partners. Because there's divergences. In my work in Untitled, where we try to bring medicines to the global south more quickly, we have an NGO delegation and we have a community delegation because we're in alignment on many things, but there's divergences. We have people advocating on behalf of us or on the grassroots, but we are the grassroots. We have our finger on the pulse of what's happening, what's needed, and how to do it, and we can be very creative about it. So differentiate and have us all there, because all voices need to be valued equally and to be listened to. And so that's another point that really came to the fore when I was looking at this. I was floored to note that there was a HIV action plan.
There will be.
There will be. Or that it's already being developed. Okay, great. Because this was news to me. I only read this 2 days ago. I know I should have probably done it earlier. But I was like, what? This is amazing. I'm like, so what's happening? And if I could talk about what we need to do for HIV, I could do it for 3 million years. And these are crucial conversations that need to happen at the very beginning of these conversations with community partners and not just be told at a conference or when you read a strategy 5 weeks too late. So this is something that I really want to encourage as well, is like true community participation in this. In the Model Care and HIV registry, I would really like to know if we're getting only socio-demographic data, or will you be incorporating patient-related outcome measures?
In the HIV registry?
Yeah.
Do you want me to answer it now?
Yeah.
So PROMs are currently included in a pilot that's being done.
Okay, great. Great. You see, we're already making progress. This is fantastic. On the topic of legislation, so PEP and PrEP, you talked so well, Park, about access to PrEP and how we have to get better at that. PEP was actually quite an interesting one, and it came up from a legislative framework issue. And how fortuitous that we have the chair of the health committee right beside us, everyone, hard right. So one of the issues with PEP is for getting like community pharmacists to dispense PEP is that legislation has to change. I think I'm correct. So based upon our targets of reaching zero new HIV infections and AIDS-related deaths, and the commitments in this strategy, hopefully can be expedited and quick enough, because I know these things can take forever. And so hopefully that's one thing you can look into, Parg. Just the vision. I just want more vision and creativity. Like when I was in Sydney for World Pride, they had a pop-up tent where you can get your Mpox vaccine. They literally threw PrEP and PEP at you like they're Skittles. Like they're like, freshen your breath, go have the best sex of your life. It was insane. Like it was just given so easily. And if you had chemsex issues, you could talk to someone there and then. It was just really fun and creative ways of doing it. When I went to New York, I had a friend who went to get PEP in the 7 days war of PEP, community pharmacist, no prescription needed. It just feels like we are always just 10 steps behind. So if we can change these legislative frameworks, if we can get this collaboration, we can find really fun and creative ways of getting these interventions out to those people who need them. I'm not looking at you, Fiona, because I don't know what you're thinking about this. But I also do want to give a big shout out, because today, if I'm not mistaken, the PrEP clinic in the Boiler House has just opened, or been launched. No! So now we're giving PrEP to MSM, people who do not maybe identify as gay or bi, or who are on sex on premise place. And so these are really fun and amazing ways that we are already giving out PrEP to people who need to get them. Okay, I don't know how long I have left. Okay.
Right.
Sorry, PrEP and campuses, amazing. Yeah. Jenny McGuire, shout out to her. She just went up to the GP and was like, I want to get free PrEP in for students. And GP's like, oh, let me look into it. And they got it within a few days or weeks. And so I want to say thank you for making that pathway super quick and efficient. I think that needs to go across all campuses, as well as testing or even user-activated SH24 testing. Most young people that I talk to say, I'm not bringing in a sexual health test where I live with my parents, but most young people live with their parents now. So I think this is really...
Not so young.
And not so young, yeah, exactly. Unfortunately, that's another thing we have to sort out, Social Democrats. I know you're going to do a good job on that. On the chemsex, look, I have a million other points, but I'm going to end on this. The other day, I want to tell you a story about this gorgeous guy. ginger hair, brown eyes, met him every Friday night on the dance floor, as flamboyant as can be, went to arts college. I adored him. For 3 years of my life, we made super close friends. One day his friend walked in on him, he was dead. I only found out 2 months ago it was a G overdose. The other day, I was talking to my other friend, he said his roommate, he has to find somewhere place to live because the police banged through the door because his friend had a psychotic break, a met psychotic break, induced psychotic break. And now his friend will have to go to in front of a judge soon. I hear time again about how I have friends who were raped, drugged and raped, or gang raped at these parties. So why am I a little bit furious, if you may? It's because for so long we have seen this go up and up and up, especially in my community of people living with HIV. As we've seen with the EMIS data, 15% of respondents of people living with HIV engaged in chemsex. My friend Jordy just said the other day, and it stuck with me, we may survive HIV, but we may not survive chemsex. I've seen so many of my friends lose their families, their friends, relationships, their minds, their lives, and we have got nothing or almost nothing. And Graham Ryle can't take on everything. What the hell are we doing? This is such a big issue and we're not talking about it. It took PosVibe, where we lose money. We don't get money to bring people to talk about their experience living with HIV or to do community groups or chemsex. We have a great booklet by Man to Man, and shout out to you, Power, for pushing for that. But for years and years and years, we have done nothing. And this is becoming a worse and worse and worse health issue. So I'm happy to see that some things are happening. What I'm not happy seeing is that we're scoping best practice in Ireland. How many times have I seen my colleagues in conferences around the world, chemsex forums, AIDS conferences, AIDS Impact, where we are already talking about the best practice for chemsex, and yet we're still waiting on more surveys for anything to be done, or for funding to be done, or for anyone to even mention it in other NGOs. It's an uncomfortable conversation, but I'm uncomfortable when I hear my friends call me up saying what happened, but they do not want to go to Dublin Rape Crisis Centre, they do not want to go under there. So I have lots more notes. That's why I need more than 5 minutes reflections. And that's why community need to be the heart of this national sexual health strategy. Thanks very much.
Yeah, Rena Tarpey is my name. I work in GOSH, which is a registered charity now for about 35 years and funded by the HSE for about 32 of those years. I've come to it, I suppose, to the table today to reflect in a very different capacity in terms of our regional and rural brief, you know, which is the communities that we serve in not only Limerick City and County, but in the counties of Clare and West Clare and in Tipperary and in those rural areas. So for us, when I looked at the strategy and how it had moved from the first strategy to this, you know, for us collaboration is key, particularly in those rural areas, like Limerick and you know, the Clare, because for us, you know, we have a great relationship with our public health consultant, Kenneth Beattie, and the likes of, you know, senior health promotion officers, to the point where, you know, we all come together to make submissions like we did last year to the sexual health charity, when there is a smaller population down in that area of the West. So for us, you know, we even GOSH, even as a charity, we co-facilitate the foundation program, you know, in the Midwest, which for us is a key part of the strategy, which is that collaboration. When it comes though to issues like, you know, sexual health promotion, going on sexual health services, for us, some of our area that we focus strongly on are populations at risk, like, you know, the minority, the ethnic populations, those that are marginalized. And we have done some work this year, some academic research with Mary Immaculate on the experiences and sexual health experiences of migrant women and migrant men. And it's amazing how we're doing research now with Mary Immaculate, because going back to to Robbie's point about when the condom scheme came out 10 years ago, we went to the third level college, and the president at the time, who was a priest, came up to us and told us to get off the campus. How dare we give out condoms? And now we are actually doing, you know, research with them. Of course, literature in Ireland, well, there was one big piece, of course, with the Crisis Pregnancy Agency about 12 years ago, but research on migrant men and their sexual health experience is quite scant. And it comes back to some of the conversations that Derek had this morning concerning consent, in particular with migrant men, and boundaries around that. But you know, it remains the case in those communities. You know, the degree of discomfort is evident, and this is why the sexual health strategy, those that are well educated and well informed, will probably access services more readily than those that do not have that capacity. And that is why it is so important that, you know, organisations like GOSH continue to work on the ground with people who maybe do not have that voice alone. This week we just had a workshop with migrant men from the local IPAS centre on sexual health. Their knowledge of HIV was incredible, absolutely incredible. But again, the boundaries in relation to consent was surprising once again. Just two gaps that just I thought worth mentioning, and James, you stole my thunder when we were talking about I'm not confining everybody that's old to nursing homes, but that population of people living with HIV that are growing older is a gap that we have felt on the ground in County Clare in particular, and also working with a nursing home with somebody and members of the trans community, where when it comes back to that capacity building for people and professionals, that they don't have the tools. Thankfully, they make contact with us, and we're doing everything possible to facilitate. But there is that generation and gap there that perhaps, you know, whilst we always welcome strategies, it is something that maybe needs to be addressed as well in more detail. Another area we work with, again, and it's just a niche that what we've worked is those with ID. You know, with intellectual disability, the idea of somebody with an intellectual disability enjoying sexual pleasure was unheard of. And we have worked with Enable Ireland, with Rehab, with Resilience Care in developing a programme for it to be sex positive. And we're working with a couple at the moment who are two women who are in a setting in the community that are trying to navigate their relationships. So again, that is something that could be, you know, in the future addressed in strategies with maybe more of a focus with that ID in mind. And even something simple again, like, you know, when we talk about, the making every contact count, like we spend so much time, healthcare professionals, on things like alcohol, tobacco, you know, mental health. Why not include sexual health, you know, in that? And we did do that submission last year to the strategy, and it could be something simple like Bernard's trial there in the SHO9 area, which is something kind of similar from that perspective. And you know, I'm always trying to be positive, and always have been very positive about the strategy. We have down in Limerick huge staff shortages in the STI clinic, no HIV doctor. And for us, we're fortunate that at least we have that relationship where sometimes we can have that overspill. But, you know, we look at the barriers. At the very best of times, it's overwhelming, you know, for people to go into an STI clinic. So again, the support of the sexual health programme in allowing us to do that type of non-clinical testing environment, where those that we have built up relationships, particularly with sex workers in Limerick, the trans community, that can come into a non-clinical environment and get tested is critical for us in building that trust within the community. We're also, as you know, we're currently piloting the home testing, the click and collect, as we call it, which whilst, and again, dare I say, sorry, but men and bloods, it's and the SH24, the women just don't, you know, not a bother. But you know, it's another alternative for those, you know, because we don't test, let's say, on a Friday, because if there's a reactive, you know, there needs to be that psychosocial type support. So sometimes the click and connect gives them that way of testing, being able to go home saying, look, at least I know I can now, you know, I know my status, or at least I'll have the weekend not to fret about it. And we have some initial feedback from Justin as to what's coming back from the NGOs, which we're feeding into the the sexual health program at a meeting last week or next week. But, you know, one big thing is the HIV. You know, we are, and we had some funding, a small bit of funding earlier in the year to develop implementation plans from an NGO perspective. We have the implementation plans there ready, but we do not have funding to engage a project manager. And I think it's acknowledged, you know, by all parties that we need project managers to be able to collaborate and reach that, you know, goal of eliminating new transmissions. PrEP, delighted to have a new doctor in Limerick. Part of the feedback, again, anecdotally, we're getting from Ken and others was, you know, a lot of local GPs are just completely unfamiliar about criteria or availability. And having somebody at least that has done that training in Limerick, you know, again, is welcome, because we're getting calls saying, where can we get it? Where can we get it? We're ringing Cork, where can we get it? So from that perspective, more done, you know, there has been a lot done, and more to do from that perspective. I think, again, the issue of trans healthcare, I think we have had a number of discussions about that here today, and that is something that is always on the top of our agenda when we speak to politicians, as well as the issue of chemsex as well. And just again, and one final point about the strategy is the continued rollout of the condom distribution scheme. We actually also separate orders when we request condoms or lube. So it's interesting, you know, we'll discuss those figures about who orders the lube and who doesn't, because we take stats of, you know, gender orientation as well. But it's great to see doctors now. We're doing a campaign, an outreach campaign on the 9th of October, where we're going to every single GP in Limerick City with the QR code. So we'll be waiting to see if we get some take up. They're my reflections, really. You know, it's always positive to see a new strategy being implemented. Investment has come, but more investment is needed. They're my reflections, really, from a country girl.
So I'm a country girl from Tip as well.
Can I say one more thing? Just forgetting about even that and Tip, but our after Pride, our second most engaged post on Instagram this year was the HIV meeting outside our train station, which was just outside our office, which was purely coincidental, but you know, it was hugely well received within the community in Limerick.
Thanks, Peter. So I want to start off by I think we need to take a moment to show a level of appreciation to Fiona Manser, who herded the cats. They didn't want to be herded, and it did Trojan work. And I know it involved weekends. I know it involved late nights. I know it involved holiday time. So thank you, Fiona, for getting this done. I'm not going to speak for 5 minutes.
That's great.
Yeah. So I'm going to divide it into two. So I'm going to, because I've had the pleasure and the privilege of being involved since the beginning, I'm going to divide it into reflections on the first strategy and what I would hope to see happening with the second. So my reflections of the first strategy were, I went into it with blissful naivety. There was no funding. The funding that came with the first strategy was me, and then Caroline came shortly after that, and that blissful naivety served me well, because I generally have a positive outlook on life, and I think that you just kept banging on doors and also working together as a team. And when we did the midterm review, my reflection was that actually the collective working together, if we have to be all working to the same vision, we may come to it in different ways, but we all have a part to play in getting to the same vision. I completely agree with you, Porrig, about the need for an action plan. the first strategy didn't have an action plan just before it was published. And the Minister of Health of the day, Leo Varadkar, said, I'm not publishing this unless it has an action plan. And that gave those of us who were involved in the implementation of the strategy a to-do list from day one. And that was very, very helpful. And I think that, I think part of the successes that we've made, and we haven't done everything, but the successes that we've made in the first strategy have been going with the wins, going where you know you're going to get wins. You're not going to get everything done. Also, Gráinne Courtney, who I am very close to and I miss dearly, although I love Johnny as well, is her bland voice will say, perfection is the enemy of progress, Fiona. So I would, you know, we just have to keep going, keep chipping away at the block. So I think that's the thing. So working together, having an action plan, being positive and chipping away at the block. In terms of the next strategy, the new strategy, I think for me, I'd love to know how many times equity appears in the strategy, because every meeting we talked about equity, and I think we've made, so we didn't before the strategy, we didn't have a condom distribution service. I think we probably have a pretty equitable condom distribution service. Before the strategy, we didn't have PrEP. We definitely don't have an equitable PrEP service. Vaccination, we have big challenges around vaccine inequity, and I have to thank the colleagues in the Department of Health who really listened to the challenges that we face around making equitable access to the interventions that we have introduced in the lifetime of the first strategy, and sort of breaking down and trying to not leave anybody behind. So with that, still having a relatively positive outlook on life, I hope to continue to work on implementation of the sexual health strategy in my remaining time as clinical lead. And so hopefully equity is the big thing for the second strategy, I think. And teamwork is always teamwork.
Thank you so much to everyone there for their incredibly quite diverse perspectives. And I guess a strategy is only as good as what it facilitates, what it enables, and what it sets in motion. And also, it's only as good as its kind of future-proofing. So in terms of how this country is going to change over the next 10 years, given the changes it's already gone through. We have about 10 minutes to throw it open, maybe 15. I don't know how long Daniel wants to talk for. To throw it open, but so comments, it doesn't have to be questions, it can be reflections or comments from the floor, please.
I think that there's many positives around the strategy and many aspirations which are really great. My second favourite topic to talk about, one of the things I found quite interesting is the only reference to nurse-led services is in higher education, which seems absolutely bizarre. That is the only reference to nurse-led services in the action plan. So I know there are further action plans. And I suppose the question is more around the aspiration of transforming sexual health services beyond testing and treatment, which is the main focus. How do we get there? We're not there now. And a lot more resource and expertise. And it's not just in medicine and nursing that expertise. So maybe Fiona, where would your vision be in terms of getting to that?
So nursing is specifically called out in one of the recommendations categorically. It was actually the CMO who requested that. Okay. Yeah. And so just hear me out for a second. So if it isn't in the action plan, it's definitely in the recommendations. And actually what I failed to remember in not having notes before I spoke was that the big thing I think for the strategy, in addition to equity, actually is the model of care. And the model of care is so important because I think we have a model of care around how asymptomatic testing could be done, as in, you know, for a large proportion of people, the home STI testing service will work, but it's not the only solution. We have a quasi model around how PrEP care can be delivered, but we have so we need to develop a robust model of care with an implementation plan and resources that are needed to implement the model of care. And within and just in terms of co-creation of that model of care, there will be engagement. Like, this is not going to be done in splendid isolation. This is going to be a co-creation process. All of our working groups have broad representation on it and have since the very beginning. Within our clinical advisory group, which is sort of a group that I answer to from a clinical perspective, the clinical team within the programme, they kind of give us advice, and it's primarily made up of doctors. But in the early stages of developing the scope model of care, it's really clear that the role of the nurse is really, really clear, but also there's an acceptance that everybody who's involved in provision of sexual health care should be operating at the top of their license. So we shouldn't be you know, we shouldn't be having people to do things that they could be doing more. And I think one of the big shifts that we've seen, certainly that I see it in clinical practice, and other colleagues I think would agree, that the introduction of the home STI testing service has really changed the complexity and the vulnerabilities and the needs of people that we see within our public STI clinics. And that is good, because that is what we, within the public STI network, is we are trained and should be doing. We should be, the people who are able to navigate systems on their own should be able to do that and be empowered to do it. But people who need, so absolutely nurses, it's everywhere. It may not be explicitly mentioned, but it is definitely mentioned within the recommendations. I know that, definitely, because the CMO specifically asked for it.
And I think that it's come up recently around the prep, you know, how prep is delivered, that the nurses could certainly have a bigger role there.
No, we have multiple nurse prescribers for prep already, some sitting in this room.
Yeah, just to add.
Sorry. No, you okay? Good.
I'm just going to add on that. I do think I did my master's on nurse-led, like an AMP service, and I think it was fine that it was, like, I suppose, well received by people. Like, there's not that many complex people coming in, and it's a preventative measure. And like the renal function, like, it's like, you know, obviously it's a guideline, but I think it could definitely be nurse-led for prep. I know.
Yeah.
Oh no, I'm just yeah.
I mean, most of our services have nurse-led clinics.
Yeah.
Sorry. Yeah, there's a few things that was said that, I mean, I wasn't going to say it, it was struck me, just we're coming from a place where, if you compare it to where we were years ago, I mean, but there's a few things that wouldn't have happened only for certain things. There was outreach workers. There was nurse-led STI testing up in the outhouse. There was the Gay Men's Health Service, the man-to-man. And the other thing about those is they're not only NGO or voluntary, they're also statutory. And for a long time, we've been working together in this country. And I think we have to build on that rather than, and that surprised me within the strategy, it wasn't mentioned. And that man-to-man is not mentioned. And these are successful stories of how to approach this. The big gap to me at the moment is outreach. And as Robbie mentioned as well, there was a time when the Gay Men's Health Service had an outreach team. They had a counselling team. And the nurse team then used to do the testing up in outhouse. They're gone because part of the way the system and the money, and we need to relook at that. And we really need to relook at employing outreach teams that specialise in certain areas, like the chemsex, because otherwise it's not going to happen. And we need to resource them and we need to interlink them. Now, Johnny mentioned it in his presentation for the Gay Men's Health Service, and I was delighted. So I suppose I'm biased on that level, but I know it works because it has worked. We've done it, and we need to build on that, and we need to resource it. And that's why the other thing I'm mad about is there's another conference on Monday. We don't need those type of other conferences. We know how to do it in this country, and we've done it well. And I think that's all I want to say. I don't know.
Thank you, Mick. There's a couple of you. Did you want to respond, Ellen, or?
That's
okay. Is it Chris? Is it? Yeah.
Yeah. Hi. Yeah. So Chris Doon from University of Galway. It's great to see. Of course, I'm biased towards wanting to see actions around that relate to the importance of research, because that's the only thing I have to contribute here. But I just noticed something, you know, in general. I think since the first time I went to one of the gay health forum, that so much of the research ends up being kind of descriptive of what the issues are, what the problems are, and there aren't as many opportunities to do research and get research funded that's focused on, like, how well are the actual interventions that the state is and community organizations are involved in, or how well are they working and how can they be improved, or, you know, things like say, you know, there's actions here, but then, you know, not clear ideas around how those are going to be evaluated. And I think if you tied them to research, then there would be good independent evaluation of those actions. So I just wondered if that's something. Most of the actions around research describe things like surveys, qualitative research, which, you know, both methods that I use that and are very useful, but it's all about kind of describing what's happening, right, in terms of people's lives. But I think we need more evaluation research in the sexual health arena here in Ireland. And I just wonder if anyone has any thoughts about that and how we can get the funding for that.
I mean, there are lots of resources within and funding mechanisms, I suppose, within the wider health service, but Fiona, you'll know more about the.
Yeah, I mean, I think so a couple of years ago within the clinical team within the sexual health program, we kind of said, look, we need to include research as a sort of, we need to embed research as part of the work that we do. I mean, we started in 2015 very much on the back foot. We did a lot of work to get done, but actually, exactly, we need to start evaluating things, not from a service user perspective, not solely from a service user perspective or from a service provider perspective, but also from a value for health perspective. And we need to ensure that the services that we're providing are good investment and that they are flexible to changes in people's circumstances, changes, you know, and that they're flexible. And it needs to be kind of that research piece needs to be living. So I think the opportunity that the evidence for policy call around you guys have responded to with Shift and then with Preptimize is that's kind of where we were going within the program. Like we need to push into this space. And also we need to, with the home STI testing service, we need to do evaluation of that from a cost perspective and a value perspective. We know everybody loves it, but not everybody loves it. The people who give the feedback either really, really love it, and then a small number of people really don't like it. And that's just speaking to the fact that it's not going to work for everybody. But we really need to ensure to monitor it on an ongoing basis and how it contributes to our overall sexual health economy. And some nice work has been done on that in the UK in the past, and we've had a couple of meetings with people around doing that. So I completely agree with you that we not only have it's not just because research is important, but we actually have an ethical responsibility to do research as well. And in doing that kind of research, we need to be inclusive, and our exclusion criteria need to make sure that they're not exclusive. For example, one of the things as a woman I found always very insulting is that women of childbearing potential, I mean, were excluded from studies. I mean, that's actually potentially does more harm. So yes, I completely agree that we actually have an ethical duty to do it. And I think that within the clinical side of the program, the rest of other aspects of the program, like Nicola leads a really good research team, which is looking at a lot of survey-based work. But I think from a clinical perspective, we've got a lot of work to do as well, and we've been planning towards that. And that's the kind of, when I step down as clinical lead, that's part of the legacy that I would leave behind. You know, that I want to see that becomes embedded in everything that we do.
Can I just make a comment on that? Just one extra thing. When we talked about inclusion of voices and equity then equity of voices in this research, I know one of your deliverables was commissioning a research project on the long-term sexual health needs of sex workers, for example. And I would love to see sex workers as PPI on that, and not just the likes of, you know, Ruhama or whatever the name is, who are like really anti-sex work as well. And if I could talk for my sex worker friends, which I will not, but I imagine if you do ask them to be part of this topic, this research project, they would want to know the impact of the Nordic model on their sexual health over time, which wouldn't be collected if you did not have them as PPI. So if we're doing research on the trans community, which you are going to commission, we hope, and is a pledge, we need trans people, many of them PPI, to make sure that their diverse voices are helping to guide this research. So I just want to make sure that is our funder just ran away, but okay, excellent. But to make sure that this is embedded within the research calls as well. So I just want to make that point.
Can I just add a point to that? Just speaking as my role as a researcher for many, many years in precisely this area. And it speaks again as well to Nick's point and indeed to Chris's point, that you need to be very smart on what you invest your research funding in, and ethical about it as well, because it's extremely expensive and extremely onerous. So evaluate smart, you know, don't start reinventing wheels in Ireland. There is huge evaluations done all over the world, which we can then think through what an evaluation here would look like. But I think, honestly, the most important thing really in terms of knowledge into action and knowledge into resources and getting money, I mean, I'm so glad there's an Irish National Survey of Sexual Health, because that's going to bring money into this area. as we've seen in other countries. It's very important. But what is really important is some kind of a community-based research and knowledge strategy, which defines what the knowledge agenda, what the research agenda should be for the next 5 years. And I think this kind of forum, and that's why I'm getting back to Mick, this kind of forum is the forum to generate that kind of a strategy. So what is the research that we want done, and how do we want it done, and how much money do we have, and how are we going to invest it in a way that's really going to work? I see, having come here recently, that there's a huge competition culture around research, which I don't think is very helpful. And there's a kind of interesting relationship between academia and government, which is, well, let's just call it interesting. But I do think that there is a chance here for this community here to take a kind of front foot in terms of defining the research agenda and how we're going to get research into action. Sorry, that's just my little tuppence worth, and I noticed that, David, you had a question there.
Yeah, I suppose on the back of John's question, just about the representation of nursing within the strategy, I found it was lacking as well. I think that I think that we have a fantastic collegial relationship with medics, and I think most of the really good nurses that I know working in sexual health have had the opportunity to work with GU clinicians and have learned so much from them, but there's no sexual health training program for nurses in Ireland. There's no opportunity for us to create our own knowledge and to do our own, training. And then specifically, I suppose, within that, the role of the sexual health advisor wasn't, and that's my role, so I'm biased, but I think we spoke a lot today about how we need to generate, really robust data around epidemiology and disease. And a lot of the people who provide that in sexual health are sexual health advisors. We complete enhanced surveillance forms. We get that behavioural data and get it back to public health. And I've had the pleasure of working closely with HPSC over the last year as well, in developing that. So I just think it's a real opportunity to grow and to expand sexual health services nationally by investing in nurses.
I'll say so. We don't have enough GU genitourinary medicine
Absolutely
in Ireland either, David. So
I'm going to call it to a close there because I realised in my little rant that we are really at time, and I want to invite Daniel, who is going to give us a little reflection and close us up, thankfully, because we probably need a bit of shouting up as well.
All right.
No, it's great to be able to sort of have this opportunity to try to give a summary and a close, but I promise we will be done at 4:45 because we're already over time, and it is Friday evening, and I hope most of you will join us afterwards for some drinks at Street 66, is that what it's called now? I still think it's called Front Lounge, but I know it's not. But yeah, hopefully you come there because it'd be great to continue this networking and connections afterwards. Because I think that's really what the Gay Health Forum really is about, is having these opportunities to really have everyone come together, hear from so many different perspectives, we've had some government representatives, we have with some of the academia, some of the actual practitioners, and also many other groups and the community in particular. So it's been really great to have this opportunity to connect, because from someone who's coming and watching from the outside, I mean, we really don't, you may think this is normal, but in a lot of places it's very difficult to have this type of interaction with people. We're in this atmosphere of fear, and people aren't able to speak openly and freely and be able to share criticisms and challenges of a new strategy, but knowing that those criticisms are taking as true feedback and wanting to see how best we can improve and to work alongside community. So I really do think it is amazing, and that's why I'm so happy that I'm still able to be connected with the Gay Health Network board and to see this work continue. But again, it's a challenge, and this is being the 22nd Gay Health Forum, which is also amazing. I wish I checked before I came back what was the first Gay Health Forum I went to. It must have been at least 15 years ago. So it's great to see that this is also going on, because in a lot of other spaces, where there was such great engagement, it's also stopped. And you don't see that they're seeing this wide continuation of over having it, just celebrating last year, the Gay Health Network of 30 years. I think that's also a testament to the work that's being done. But just to give some thanks, first I want to thank our partners, including the Gay Health Network member organizations, all of our speakers, the chairs, to introduce everyone, and all of you who joined here in person throughout, and most of you stayed for the whole day, which is amazing. And I know there's been some people online and been able to listen in throughout the day, which is great, and I'm sure they've enjoyed the talks as well. But I also want to just really thank IREC for hosting us today. I mean, I think this is an amazing space to be able to have everyone, and I think it's also a very the title of the organization. I mean, it's a really important thing that we're able to have that forum here as well. And that's where I think some of his words that he had today, I think was just taking it from Liam directly. He did make a note about the Gay Health Forum. He said it really is an example of productive collaboration between community and various sectors, and which can deliver change. And I think that's a really nice thing for him to express and see what can be done. And it was also great in the morning event here from the Minister of State, showing her words of expressing her full commitment and support to the work that is being done here. So I will go into too much because I said 4:45 and I have 1 minute. But I think it really is that the forum is about dialogue and connection with and between communities. So I think it's again great that you're all here. Why there's important of evidence and how this evidence drives of policies and services. We need to make sure research continues to be able to generate that evidence that we need, but making sure that this is community led, community driven, or co-created, all these different community elements that can happen. We know how partnership, collaboration, engagement are really essential between all of these areas. And we're reminded throughout the day that our responses must always be people-centered, rights-based, inclusive, and sex-positive. And obviously for the Gay Health Network, there's a lot of work that will continue going on, and that will be able to continue delivering the work. And in particular, hopefully we're able to bring everyone back again next year for the Gay Health Forum. So anyways, I'll leave that there and thank everyone for coming today.
Yeah.